Good morning, everyone. On behalf of the Vascular and Endovascular Society of Maharashtra and Goa and 𝐬𝐮𝐫 Hospital, I welcome you all to this scientific meet called Thrombosis Update 2024. It's a Sunday morning. I'm extremely grateful to all of you who have taken time off to join in. We have for all of you arranged a lineup of some stars in the field of thrombosis management. And I hope that at the end of the program, we would have helped you to clear up your concepts on how thrombosis presents and is managed in the most scientific manner. I will not dwell too much into the details of the program as the context of this thrombosis update will be dealt by Dr. Paresh Bhai, and he'll elaborate on that. Just a brief on the format of this meeting. Each of the topics will be preceded by a classical case presentation, the topic, and will be followed by the expert talk. I do strongly feel that it should be an interactive session, so I would request you to keep your questions at the end of the session so that we can have a more of an interactive kind of a knowledge sharing. Before we start the main program, I'd invite Dr. Amish Mhatre, Secretary of the 𝐬𝐮𝐫, that is the Vascular and Endovascular Surgical Society of Maharashtra and Goa, to please say a few words before we get on with the program. Dr. Mhatre.
Thank you, Dr. Shekhar. Good morning, everyone. I am Dr. Mhatre. I'll just introduce 𝐬𝐻𝐵. 𝐬𝐻𝐵 is basically a surgical society involving the states of Maharashtra and Goa. It is a vascular and endovascular surgical society of Maharashtra and Goa. The idea of having a separate society for vascular surgeons was launched somewhere in November. So this is the first meeting which we had, and the planning for the future of vascular surgeons in the state began from this stage itself. It is basically 𝐬𝐻𝐵 is an initiative amongst vascular and endovascular surgeons of Maharashtra and Goa with the aim of promoting awareness and education to the medical practitioners and masses of the state regarding the vascular disease. The primary objectives being medical objectives, educational objectives, and social objectives. Now, right from the beginning, right from day one, our founders were very clear that we need to have a society with the aim of a long term. We don't want a society to start and finish within 2-3 years. So keeping that in mind, first thing which we did was register the society in Society Act and the Public Trust Act. So it is one of the few societies in the country which is actually registered, and all the activities of society are monitored and governed by the trust. registrar. We have few, at present, we are 28 members and growing strongly. Coming to 𝐬𝐻𝐵's primary objectives, awareness. Limb saving has been a concern to many people. All of you must be seeing patients who have threatened limbs. So one of the vascular surgeons, even before the endovascular and even before VSI is a Vascular Society of India was formed. The surgeons have been trying to do procedures to save the limbs, starting from surgery, endovascular, hybrid procedures. As a vascular surgeons, we treat the wound, manage the wound, we do bypass, and we do endovascular. So complete package, any patient comes to us, we see the patient and we give all our efforts, whichever is suitable for that particular patient, and try and save his limb. This was the awareness program. 6th August is celebrated as a vascular day in the country. This became a hallmark event. This 2023 became a hallmark event where all the vascular surgeons in the country came together and had a walkathon, spreading the awareness of vascular disease. So this is what we do. This is what 𝐬𝐻𝐵 does. In our state also, we had similar events in Nagpur, Pune, Nasik, and Thane, where all the vascular surgeons came and spread the awareness of amputation-free India. Education-wise, yes, we are going strong. Last year, we celebrated 30 years of VSI. VSI is the Vascular Society of India. Its annual conference, attended by more than 400 delegates, almost 40 international delegates were there. And we gave special concessions to the 𝐷𝐸𝐻 members who came, faculties who came and attended the conferences. We do have, continuing the education programs, we have programs where we try and give education to the industries who are associated with vascular diseases, make them aware of what is the latest things which are happening, and we try to educate them. Similar programs have been done in Pune, Massicon, Ulticon in Pune. We teach students. This was in Nair Hospital, where we had a small CME followed by a suturing workshop, where we try and teach the students the basic of suturing. Any patient coming off trauma to a clinic, we try and teach them. At least they should understand what is the basic of suturing, how to do anastomosis in the practice. This is basically for the students, and we are planning to go ahead and try and teach the general surgeons also in the future. Similarly, Nasik, we got a very good response in Nasik Massicon, where we had sessions from the VSI members. President and secretary had come. There was suturing workshop and CME programs. As 𝐬𝐻𝐵 being new, we are trying to increase the awareness. We are trying to start our own websites, a very interactive website where finding the surgeon will be much easier. Then where to refer, which patients to refer to vascular surgeons. And of course, without social media, the things will be stuck. So we are going full into social media platforms also, like Instagram and Facebook. We do have our aspirations. We did have our limitations, but we are looking forward to create awareness, the patients should be benefited from the newer techniques, the newer technologies, the newer medicines. And of course, this will not be possible without the help of the physicians who primarily see the patients, and the drug industries who support us for the teaching programs. India has always been known as the diabetic capital of the world, a name which has stuck, and I don't think it's going to go. We do not want to see that it becomes the amputation capital of the world. Thank you.
Thank you, Dr. Mhatre. Now we get on to the main part of the program. To start with, I'd request and invite Dr. Paresh Pai to come and set the context. I think Dr. Pai needs no introduction. He's probably one of the most senior most and most reputed vascular surgeons of the city. And I'd just like him to come to the dais and deliver his wise words.
नहीं तेरा है ये
Good morning. It's indeed a pleasure to be here with all of you. Thank you, Dr. Shekhar, for the invitation. And you all heard our friend Dr. Mhatre give us a talk on VASOMAG and what it is for and what we are aiming to do. Today, I'll be spending a few minutes with you explaining to you the context setting for thrombosis update. So, you know, in medical or every time in life, there are different viewpoints. What do you see here when you see this picture? Do you see a face or do you see a word? Anyone? Excellent. That's not me, by the way. Or you see the word, you see a word there or just see building blocks? Excellent. What about this? What do you see? You see an old lady or do you see a young lady? Yes, but young or old? Okay, so it all depends on perspective. And the major hurdles we face when we're dealing with thrombosis, it needs a high index of suspicion. There are different specialties involved in treatment, so there are too many cooks. And as a result, there's sometimes a delay in providing comprehensive care. So this is the toothpaste, or the toothbrush telling the toilet paper, you know, I have the worst job in the world. So really, it's how you look at it. So what is important is to differentiate between thrombosis versus embolism. So thrombosis is a clot which takes place locally, and when it breaks off and goes distally, it's called embolism. This can involve either the arterial system or the venous system, or there are special vessels which get involved, such as cerebral venous thrombosis, mesenteric, hepatic, portal vein, so many. So today's session is going to deal with venous, arterial, mesenteric. And when we look at this, when you look at thrombosis, you have to look at both aspects. Prevention, which can be either primary, before the event occurs, and secondary, that when you don't want a recurrence, or it also involves treatment. So all these things will be looked at. So what are the consequences of delay in diagnosis and treatment, whether it's arterial, VTE, others? Lack of comprehensive care, incorrect choice and dosage of newer oral anticoagulants, and choice of using untested generics over original molecules with proven efficacy and safety. So today's talk that I'm going to give is going to cover these points. What is the epidemiology and the incidence of thrombosis? What are the consequences of delayed diagnosis or inadequate treatment? And common shortfalls encountered in clinical practice. A clot can disrupt the flow of life. It all depends on which vessel is involved. And it's very important when you treat this that we know nothing to chance. So we give comprehensive care and we take care to see that it doesn't happen again. So let's focus on acute limb ischemia. We look at the epidemiology and incidence, consequences of delayed treatment, and common pitfalls or shortfalls that we see. So what is the incidence of acute limb ischemia? In non-traumatic, acute limb ischemia is 10 to 15 per 1 lakh population. This may be related either to thrombosis in a diseased artery or from an embolus from a proximal source, which could be a proximal artery or could be cardiac being the most common. Sometimes there's a dissection of an artery which can mimic thrombosis and pose difficulties in treatment. Because typically when we go to try to treat occluded arteries, we use what is called as an embolectomy catheter. And these are situations where you don't get much thrombus out and you think you have done a great job. Transient, there is some amount of flow. And when you close, it reoccludes. So therefore, this dissection is something which can mimic but has to be carefully done. So suppose, what are the consequences of improper treatment? So it's risk not only to limb, but also to life due to delay. There is associated nerve damage, which usually takes place if the severe ischemia continues for more than 6 hours. Muscle damage with compartment syndrome. And then when you restart the flow, you can get reperfusion injury with multi-organ failure and death. Sometimes there is risk of rethrombosis, especially if the cause of the acute limb ischemia is left untreated, or if anticoagulation is either suboptimal, which could be either in terms of inadequate dose or inadequate or lesser duration of anticoagulation. Commonly, this is wrongly diagnosed either as nerve root compression, or sometimes when you have a clot which comes and sits at the bifurcation of the aorta, there's suddenly paraplegia, which is Lerich's syndrome. So a lot of patients are misdiagnosed as neurological. Or sometimes you have leg pain, which is treated with analgesics. All this results in delay in treatment. Sometimes you also see situations where there is correct diagnosis, but improper treatment. Sometimes people give trial with anticoagulation when surgical intervention is absolutely critical in the correct time. Sometimes the source is missed. So you have a cardiac source or a proximal dissection or a proximal ulcerated plaque with thrombus. Sometimes you have a situation where the distal outflow is not cleared. So these are all situations where you get rethrombosis. And many times you see a wrong procedure which is used. For example, if you have a major artery which is occluded, somebody attempts to do thrombolysis instead of thrombectomy, huge amount of thrombolytics, there's a delay in revascularization, and the patient loses not only the limb but also the life. This is as far as acute limb ischemia is concerned. Now, I don't know how many of you are aware, but March is a DVT awareness month. And this is a time where all vascular doctors, as well as pharmaceutical companies, make a concentrated effort to push and create an awareness of deep vein thrombosis and pulmonary embolism. So that's one of the reasons why the thrombosis update is scheduled for March. So when we look at VTE, we look at epidemiology and incidence, same thing, consequences of delayed diagnosis and treatment, and what are the common shortfalls in treatment. 10% of overall deaths during hospitalization are due to pulmonary embolism. 10%, that means 1 out of 10 deaths. 75% of deaths due to PE occur in medical patients, not surgical. Everybody thinks that surgical patients are more prone for DVT. No, even medical patients are. 5% of medical patients may die from PE during hospitalization. 19% risk of DVT during hospitalization for acutely ill patients, whether it is sepsis, whether it's cardiac failure, whether it's hemiplegia, stroke. 75% of acutely ill medical patients have 2 risk factors for VTE. So VTE is estimated to cause more than 500,000 deaths in Europe every year and more than 300,000 deaths in the US. VTE is estimated to cause at least 3 million deaths a year worldwide. So in Europe and US alone, you see 10 million cases of VTE and 600,000 deaths, 1,600 deaths per day. 60% of all VTE cases occur during or following hospitalization. It's the #1 cause of preventable deaths in hospital. And 1 in 4 patients die from causes related to blood clots. 1 in 3 top cardiovascular killers are linked to blood clots. So what about the Indian setting? It was always considered that while you see VTE in Caucasians, in Europe, in US, you don't see so much in India. That's not true. So there are various studies which show that VTE is as common in India as it is in other. And not only that, The next few slides will show you that the treatment, the prevention is significantly less in India or Asia as compared to the foreign countries. So this is Sir Gangaram Hospital presentation of 2006 of patients of DVT. Found that there were 294, showed high probability lung scan. Overall, 47 of patients with high probability scan had no clinical manifestations suggestive of PE, so it can be silent. PG at Chandigarh 2007, they did 1,000 adult autopsies, and pulmonary embolism was seen in 15.9% of cases. CMC Vellore 2009, the incidence of VTE was 17.46 per 10,000 admissions, and 5 out of 1,000 in post-op patients. 𝐬𝐮𝐫 2009, 75% of patients had the highest risk of DVT and PE. Only 12.5 had DVT prophylaxis within the first 2 days of admission. Signs and symptoms of DVT and PE were present in 25.8% and 10% of patients, and 16.2 died within 2 weeks. The ENDOR study, Indian subset 2010, in India, 16.3 surgical and 19% medical at-risk patients received ACCP recommended thromboprophylaxis. So such a low number of patients. SRMC study, 1,000 patients with VTE, 19.49 admissions per 10,000. COPD on ventilator support, 40% risk. Recent surgery, 1 out of 4. Neurosurgical patients, 1 out of 5. And malignancy, 13%. It is common, it's not uncommon. Consequences of improper treatment, risk to limb or life due to delay, proximal propagation of thrombus and extension of deep vein thrombosis. So many times it starts in the calf and then progresses to involve the superficial femoral vein, proximally the common femoral and the iliac vein. Pulmonary embolism can be silent. You can have chest pain, or you can have shock or sudden death. Risk of recurrence, recurrent DVT with post-thrombotic syndrome, patients who have swollen legs, painful legs, pigmentation, recurrent ulcers, recurrent pulmonary embolism, which poses a risk to life, and chronic PE with pulmonary hypertension. What are the common shortfalls in treatment? Many times it's wrongly diagnosed. It's treated as leg swelling with analgesics and serratiopeptidase. PE is treated as COPD, pneumonia, angina. It's only when they do a CT pulmonary angio or they do a 2D echo, they find that the pressures are high on the pulmonary side. Common shortfalls in treatment, where the diagnosis is correct but the treatment is incorrect. We see the wrong choice of anticoagulation, wrong dose of anticoagulants which are used, incorrect duration of anticoagulation. Sometimes we have seen, as vascular, we get a lot of references from patients who have already been diagnosed and under treatment. So there's a problem when we use generics. Sometimes you also see that patients are not offered intervention when it is required. And also there can be an indiscriminate use of IVC filters. So it all depends on who's treating and whether the treatment is complete or not. So what is the role of vascular surgeon? That's thrombosis, that's the patient running, and now you're going to see Dr. Shekhar in action. There he comes. He was much younger, hair was black that time. So friends, it's not us. We need to team together. We need a multidisciplinary team effort to see that we give good results. We save our patients, not only their lives, but also their limbs, and improve their quality of life. Thank you very much.
Thank you, Dr. Pai, for setting the context. I think all those of you who paid attention to that excellent talk would be aware that by now that thrombosis is something which presents in many ways, and you need to get it right at the beginning, diagnose it correctly and treat it correctly. Otherwise, the consequences are disastrous, and the patient gets sucked into a wrong treatment. The more is it difficult to bail them out from that situation. That is about the context. And now we get down to the main program. To start with, we have Dr. Samir Tulpule. I invite him to the podium, and he will be, I think before his talk, he will be talking on cancer thrombosis. I think many of you know about cancer thrombosis. Many of you don't know what is exactly the link between a cancer and a thrombosis. So I think before Dr. Tulpule actually gives his talk, as per the format of today's meeting, we'll have a simple case presentation on cancer thrombosis, and I think that will set the ball rolling. It will give you a good idea about what exactly is the link between cancer and thrombosis. So I think I'd invite a member of his team. Please introduce yourself. And he will be presenting a case, classical case of cancer thrombosis, and I think at the end of it you will realize how closely interlinked cancer is with thrombosis.
Good morning, everybody. I am Dr. Amit, Associate Consultant under Clinical Hematology. I am presenting the case under the heading Cancer-Associated Thrombosis. 65-year-old Kashmiri resident, chronic smoker, and have attended with a painful right calf swelling since 2 days, and there is a noticed tender lump with red streaks over the leg, and which occurs repeatedly over the 3 months. So initially he is diagnosed as cellulitis outside and treated with antibiotics and analgesics. But it happening repeatedly, so he attributed that it due to any allergic or drug allergy or any bite. So this is picture showing redness over the calf. This is actually superficial thrombophlebitis. So ultrasound was done. It's showing the deep vein thrombosis of the popliteal vein. So he started on the oral anticoagulation, and the pain and swelling settled over 3 weeks. So we thought patient is improving, but story was not over there. So patient is readmitted with abdominal pain, jaundice, and deranged epilepsy. This is the CT scan. The CT is showing there is large pancreatic mass involving adjacent liver, bile ducts. So this mass is inoperable, so patient chosen to return to native place and passed away in 4 months. So this is the classical superficial thrombophlebitis called Thrombosis sign of malignancy or Thrombosis syndrome. It is described by the Thrombosis in 1860, and this is sign involving episode of vessel inflammation due to blood clot, which are recurrent or appearing in different locations over the time. So this is called as migratory thrombophlebitis. So he later found that same sign in himself and was subsequently diagnosed with gastric cancer and died soon after. So cancer-associated thrombosis is a major cause in mortality in cancer patient, and most common type being VTE. Sometimes thrombosis precedes the cancer and act as the pointer to possible undiagnosed cancer. Thank you. So, Dr. Samir Tulpule will discuss cancer-related thrombosis.
So thank you, Amit. And thank thank you, Dr. Shekhar, for inviting me this morning to speak on cancer-associated thrombosis. I think the introduction was very well laid by Dr. Pai on the importance of thrombosis, the delay in diagnosis, in diagnosing thrombosis, and the treatment or inadequate treatment of thrombosis. And this is sort of a classical, you could say, one of the cases in thrombosis where this patient has been coming quite often and recurrent with superficial thrombophlebitis, migratory thrombophlebitis, and at every time, he's been given some analgesics or antibiotics or some local treatment, and he's been, I shouldn't say turned away, but gone home. And then several months, down the line, when he starts coming with, abdominal discomfort, jaundice, is when, there's an index of suspicion and then scans are done. And then one would think that if you had done this several months earlier when you had initially presented, when you had investigated the thrombosis or the migratory thrombophlebitis a little bit more extensively, would we have changed the outcome for this patient, or would we have detected it sooner? Would it have been surgically resectable, and so on? So, these sort of beg the question when I shouldn't say miss, but have a more open mind of trying to diagnose thrombosis. So moving on from that, the topic for me today is cancer-associated thrombosis. And if you just have a look at the data, and this is sort of worldwide data, and you can see that about 20% of all venous thromboembolisms or thromboembolic events occur in patients with cancer. This a bit. Sorry, here. VT is a common cause of death in patients with cancer, and the recurrence rate is 2 to 5-fold higher in patients with VT and cancer compared to those with VT and no cancer. So you can see that just having a malignancy or a cancer is going to increase the risk of VT for that patient. And just with that information, you can imagine the impact it's going to have on the subsequent management, whether it's going to be surgical, whether it's going to be medical chemotherapy, or a combination of both. And it's definitely not a rarity in Indian patients. This is a retrospective study of pulmonary embolism in cancer patients from India, which showed a prevalence of P of 6.4 per 10,000 hospital admissions, almost half of which had associated DVT. And the incidence of DVT was 2.4% in ambulatory patients of cancer. So if we keep that into perspective, what Dr. Pai showed as well, that patients getting admitted to the hospital and being put on some thromboprophylaxis, and as he's rightly pointed out, that the incidence of thromboembolism is quite high in medically ill patients. So awareness in that sort of area is quite important. To start thromboprophylaxis in medically ill patients, and more so if they come with a diagnosis of cancer. So what is the pathophysiology of cancer-associated thrombosis? Why do we see more thrombosis in these patients? Now, if you think of thrombosis in general, you've got two mechanisms. You've got the clotting, which is, you've got your extrinsic and the intrinsic pathways. So the extrinsic pathway is typical tissue damage or tissue factor. The intrinsic pathway is your typical, factor 12, 11, 9, 8 activation. And then you've got the fibrinolytic pathway. So either you inhibit the fibrinolysis, which means the clot remains, or you activate the thrombosis, which means there's more clotting. And that is what cancer does. So the cancer itself secretes molecules, and these can be tissue factor, the tissue factor extracellular vesicles, which essentially propagate thrombosis. So Your final common pathway is basically producing prothrombin to thrombin, and thrombin then works on fibrinogen to fibrin. And it is this fibrin which is important in injury to form the fibrin clot, which actually forms the clot in which then the platelets get entangled and the whole thrombosis propagates. So A, it causes fibrin deposition. B, the polyphosphates as well as the podoplanin, they cause platelet activation. When you've got platelet activation, again, it propagates thrombosis. There is neutrophilia, which gives rise to NETs, or neutrophil extracellular traps. So these are basically proteins which are bound around, you can say, the DNAs, which basically then cause secretion of various cytokines, and they actually cause entrapment, causing thrombosis. Then you've got the monocytes, which can actually activate the tissue factor, which is your extrinsic pathway. Plus, the polyphosphates, they activate your intrinsic factor. The tumors produce PI1, which is plasminogen activator inhibitor. So it inhibits fibrinolysis. So when you have all of these things together, and you have got, so this is what's happening inside the patient, but physically, say the patient is obese, patient is not mobile, he's bedbound, he's diabetic. You put all of these factors together, and then suddenly you see that the incidence of cancer or thrombosis in these patients goes up. What are the risks and consequences? We all know you've got patient-related factors, which we talked about, medical comorbidities, presence of varicose veins, prior thrombosis, hereditary risk factors. So we haven't spoken about heritable thrombophilias, or even, antiphospholipid antibodies and antibody syndromes. Then you've got treatment-related certain therapies like platinum-based therapies, anti-angiogenic agents, hormonal therapies, surgeries, radiotherapy, repeated transfusions, central venous catheters. A lot of patients have either PICC lines or ports, or they've got Hickman lines, so catheter-associated thrombosis. And as we spoke about, hospitalization and immobility. Then tumor-related itself, related to the tumor. So the site of the cancer is important. Very high risks are stomach, pancreas, and brain. High risks are lung and hematological. So typically your lymphomas and myelomas are quite prone for thrombosis. Then you've got the gynecological, renal, and bladder. The grade of the tumor, so the higher grade, the more risk, stage of cancer metastasis, and time since diagnosis. And then you've got some other biomarkers, which are not hard and fast, but aid you to think about whether this patient is having thrombosis or would be going towards thrombosis. Typically, you would look at the high platelet count, the neutrophil count, you've got D-dimers, you've got the prothrombin fragment 1 and 2. But these are more or less sort of investigational research tools, but help you guide towards to see whether they can have thrombosis. So can we sort of risk stratify them? Can we predict? Can we say that a certain patient would be at a higher risk of thrombosis than somebody else? And yes, there's a corona score where you look at a type of a cancer, whether it's high risk, low risk. You look at the platelet count, you look at the hemoglobin level, leukocyte count, and sort of the body mass index, and you develop a score. And the higher the score, the more risk of thrombosis. From that, then you could decide how intensively you want to treat the patient, depending upon the treatment you're going to give, the surgery they're going to have, and so on. Now, if you look at the evaluation of anticoagulants, going back to the early 20th century, 1916, you got heparin, then several years you had got vitamin K, and antagonists typically, you had warfarin and acetrom, and all of us remember for years and all, that's all we had. We had either acetrom or we had warfarin, and you had heparin. That's it. Then there was an advent of fondaparinux, which is one of the 10A inhibitors. Then you had the newer oral anticoagulants, or the direct oral anticoagulants, and now being used across the spectrum. Now, typically, you've got two broad classes of the newer oral anticoagulants. So you've got the oral anticoagulants, the newer ones, which predominantly act on thrombin, so factor 2, which is typically your dabigatran and agents. And then you've got agents which act on factor 10, which are basically your rivaroxaban and apixaban. So these are the two broad categories of the DOACs that we use. And there are pros and cons of both. Vitamin K antagonists, I think everyone has used them. There's no burden of injections. It's an oral tablet, but there's problems because there's a lot of interactions, any dietary changes, the INR changes, they need frequent monitoring, and there's challenges to maintaining the INR within that narrow therapeutic range. What about low molecular weight heparin? It's the gold standard, but patient has to take injections. It's highly efficacious, as shown by multiple trials. There are very few drug-drug interactions and can be used when you can't use these agents orally. What about DOACs? Efficacy similar to a low molecular weight heparin. There are no injections and quite useful when your patient is living many miles away and it's very difficult to monitor them regularly. Then DOACs are an easy way out. There are fewer drug-drug interactions, but still, you need to have a look if they're having any antifungals, because typically patients will be on antifungals and they will interact with your DOACs. Cardiac medications will interact with the DOACs. They're lower cost than low molecular weight heparin. But if they've got gastric malignancies or they have high risk of bleeding or genitourinary malignancies, then one may not use them as frequently. And what's the treatment approach? Now, this is the sort of standard approach. Initially, whenever we get a patient, we usually treat them with either unfractionated or low molecular weight heparin. Then there's a sort of a bridging zone where we put them on warfarin, maintain them INR more than 2 for a couple of days, and then we switch off the low molecular weight or the injectable heparins and maintain them on warfarin. Typically up to 3 months, but if longer required, then it's more than 3 months or more than 6 months, depending upon the indication. Now, with the advent of the NOACs, there is no, should we say, bridging. So you can start a treatment and it can just continue. But again, in the real world, it's all going to boil down to the patient in front of you, what the age is, how are they going to be monitored, what the malignancy is, how intensive is the chemotherapy, are they going to get neutropenic or thrombocytopenic very often, are they on antiplatelet agents for a stroke or an MI, how mobile are they, all of these factors weigh in when you tend to select an anticoagulant. Now, whenever we start anticoagulation, there are two main things that we look at. Is the patient going to have recurrent thrombosis? Is he going to have bleeding? So these are the two main things that we look at. Now, if you look at VT recurrence, okay, so this is against DOACs versus low molecular weight heparins. And you can see that the DOACs may be having a slight edge over the low molecular weight heparins in terms of recurrent VTEs, but no significantly different in terms of bleeding. So if you look at the various trials, now one shouldn't look at all these trials with the same lens, because there will be some selection criteria differences in all of them in terms of your patient population and so on. But overall, one would think that there was no significant difference in the rate of bleeding. Now, if you look at DOACs for the treatment of cancer-associated thrombosis, and as I say, these are now just 2 select trials. There are a lot of trials in this, and if you look at different trials, you will get a little bit different data. But essentially what this is saying is this is SELECT-D and the Caravaggio. So basically, you've got the 2 classes of the anti-10A. So you've got rivaroxaban versus LMWH and apixaban versus LMWH. Now, again, mind you, you cannot compare these head-to-head because the patient mix is slightly different. The inclusion criteria of the thrombosis within these trials is also a little bit different. So I would just suggest just looking at one trial on its own. So SELECT-D is rivaroxaban versus LMWH only, instead of looking at comparing it with the other trial. But what could say that the case mix here is more or less similar here. The patient characteristics similar, so this is in terms of the malignancies. But you can see that in the SELECT-D, the GI malignancies were higher, so you would expect that probably bleeding was slightly higher in these patients. These are patients with DVT and PE only in the trials. And you can see that in the SELECT-D, these patients had a slightly higher number of PE patients included in that trial because they had also included incidental PEs. So when you look at the lower incidental VTE, they had slightly more number of patients there because they had included incidental PEs in the trial. Now, when you look at the recurrent VTE, the SELECT-D, so you're only looking at rivaroxaban versus dalteparin, and you can see that the recurrent rate of VTEs was lower, and similar with the apixaban as well. So when you use the apixaban or the rivaroxaban, the risk of recurrent VT is going to be a bit low. And the same thing with when you look at bleeding. Now, what is the real world experience? So this is a little bit of Mayo data. So what they have done is, once they diagnosed a patient with thrombosis, they come to the clinic, the patient is given a sort of a handheld device, he goes through whatever anticoagulants are required, the anticoagulant is selected, and then he goes on to the trial and takes anticoagulation for 3 to 6 months. And now they've looked at major bleeding, they've looked at clinically relevant non-major bleeding, that's CRNM, and looked at both. And you can see here across the board that they had similar rates of GI bleeding irrespective of the anticoagulations. However, one of the anticoagulants, apixaban, was slightly associated with a higher rate of GI bleeding compared to low molecular weight heparin and rivaroxaban. Looking at mortality, again, patients with rivaroxaban had slightly lower mortality compared to the other two. But mind you, these are individually institution-based studies. Still more studies with more number of patients need to be done. But what this is trying to say is that the direct anticoagulants can be safely used in a majority of cancer patients, but be wary of using these agents in patients with gastric malignancies or genitourinary malignancies where the risk of bleed is going to be slightly higher. This is flashing. Here. Okay. So what this is basically showing, this is another US study, and it is looking at essentially head-to-head comparison between rivaroxaban and apixaban. And if you look at the data in terms of recurrent VTE, I can't read it here for some reason. Recurrent VTE, bleeding related to hospitalization and critical organ bleeding, I think more or less they are similar, though in terms of bleeding it may favor rivaroxaban a little bit. The slide is stuck. I just stuck. I think that was coming towards the end of my talk, really. So there's just one slide there. So I think I would just summarize by saying that cancer-associated thrombosis is a real problem. Um, Instead of, I wouldn't say early intervention, but appropriate use of the anticoagulants right from the beginning. First, in terms of whenever they're admitted, to give them prophylactic anticoagulation, either low molecular weight heparin or DOACs. Perioperative is very important in terms of giving them the right anticoagulation for the right duration. Again, it depends upon the risk of bleeding. Usually, as hematologists, we would like patients to start on anticoagulation as soon as hemostasis is achieved and there's no risk of bleeding. And going forward is then trying to optimize their anticoagulation by either DOACs or low molecular weight heparin. With that, I'll invite questions, if any. Thank you. So if there is thrombosis, typically, if you're using low molecular weight heparin, then it's standard. Typically, I prefer enoxaparin because that's how I've been trained when I did it. So typically, you plan to give it ideally once a day if you can. So we give them at 1.5 milligrams per kilogram once a day. What I also tell all of them to try to do it in the morning. So if you want to take them for surgery or anything next day, then you've at least got a 24-hour gap. So give it at 9 o'clock so that the next day morning, 9 o'clock, you take them for surgery. So you've got a 24-hour gap in terms of doing it.
Good
Always
morning,
look
sir.
at the creatinine and the renal function as well. So the standard treatment regimes would apply. So whenever we give our whenever we start apixaban, we usually give them 10 milligrams twice a day initially for a few days and then go to 5 milligrams twice a day. Rivaroxaban is sort of 15 milligrams. We give them for 3 weeks and then 20 milligrams. So that's the standard dose that you would give if they have thrombosis already. If you want to give them prophylactically, then the data is extrapolated from the patients who have had orthopedic surgeries. So most of the data in the prophylactic setting is extrapolated from the orthopedic surgeries. So someone with a proven thrombosis and cancer, the guideline is to continue anticoagulation as long as the cancer is active. Once the cancer has been treated and there's no cancer anymore, then you could have anywhere between 3 to 6 months and you can stop it after that. As long as there is active cancer. So you have a PET scan, cancer is still going on, the patient is still receiving some form of treatment, then the anticoagulation should continue. So typically, if someone is on a DOAC, in that sort of situations, we don't tend to bridge them necessarily if the surgery is going to be imminent. So a 24 to 48-hour gap should be enough. So that's the usual general recommendation for DOAC going into surgery. If the patient is on warfarin, then we tell the patients that to stop the warfarin as soon as the INR is less than 2, to go on to low molecular weight heparin, again given 1.5 milligrams per kilogram in the morning, 9 o'clock. So that, for example, if the surgery is on Monday, patient goes on to low molecular weight heparin today or yesterday, say Saturday. Sunday morning will be the last dose for the patient to be operated at 9 o'clock on Monday. That should be enough. That should be enough. So usually, see, every patient with DVT, we don't screen for malignancy. Okay? So you're going to have risk factors. So is the patient a smoker? History, obesity, family history of cancer. You're looking at the blood reports. So for example, if they got a neutrophilia, or they come with a recurrent DVTs, those are the things where you're going to scan for cancer. Or thrombosis at an unusual site. Someone comes with a huge portal vein thrombosis, or comes with a sort of an axillary thrombosis or arterial thrombosis in young patients. You don't know what's happening. So you need a high index of suspicion for those patients. So typically you would scan the relevant areas or get a CT chest or something of that. So depending upon what your history is suggesting, which vascular bed is getting involved, is it recurrent, is it isolated, and so on.
Would age be a criteria for high index of suspicion? DVT in elderly?
So elderly, definitely yes. That would be a high index of suspicion because malignancies in that sort of age are more common. But not necessarily, we've got younger patients with massive lymphomas who come with thrombosis.
I had a patient around 65, 70, unexplained venous thrombosis, chronic, presenting with mesenteric ischemia. Means not venous thrombosis, presented with mesenteric ischemia, abdominal pain. And fortunately, when I had to operate, but during surgery, it was all on the, somewhere in the mid zone. So we closed her back, put her on thromboprophylaxis and all. On giving a reference to the hematologist, he did a cancer screen. We could not get any cancer anywhere in the abdomen or the chest. The only marker which we were then following was a CA-125 for ovarian cancer, which had just come borderline. On CT, there was no ovarian malignancy. Now, these patients, should we follow them up with tumor markers? And B, how long should a thromboprophylaxis continue?
So, first of all, I'm a hematologist, so I won't be able to answer regarding the ovarian tumors. I'll refer them to my solid tumor colleagues to see how often they need to be and how long they need to be monitored. So that's one question. Second question is how long for treatment for the ischemia. I would say that this patient will probably go on to indefinite treatment because if they've got mesenteric ischemia giving rise to an arterial, if in the future they get an arterial clot, that is going to be, the morbidity from that is going to be quite significant. So I would put them on some sort of a long-term anticoagulation, maybe an antiplatelet initially to begin with if it's an arterial bed. So then probably, if it's going to be venous, then I'll put them on anticoagulation. If it's arterial, it would be an antiplatelet.
Hi, Samir. I just heard somebody asking about the monitoring of cancer patients in terms of an ongoing thrombotic event which could determine yes or no with regards to the continuation of therapy, anticoagulation therapy or not. So to that extent, I was wondering if you would agree that D-dimer could be a good marker to keep a track of, because this is basically a hypercoagulable state, and D-dimer would be something which will be high as the process is going on, which anyway we are monitoring in patients.
Coagulation is when your D-dimers come down, and then that will be a good indication to stop. But in the context of cancer, specifically, this is a time when one needs to be a little bit more careful as to when you're going to stop the anticoagulation, especially if there's active cancer going on.
For me, secondary prevention, post cancer-associated thrombosis, would you opt for a prophylactic dose or would you continue with the therapeutic dose?
So, let us take two examples. Say I've got a patient with lymphoma, say in his 40s, has got a DVT. I've given him 6 cycles of chemotherapy. I've done the PET CT. He was on 6 months of anticoagulation, stopped. There's no disease, and I've stopped. But if he's had an extensive thrombus, I will continue the anticoagulation. So it is going to be very patient-specific in terms of anticoagulation and how long. Typically, guidelines would say that once the patient has been cured or does not require any chemotherapy and the disease has gone away. Maybe you could give it for 3 months and stop. But I think one will have to look at from case to case. Someone who's got a massive thrombosis after 6 months, I probably won't stop. I may cut it down to a prophylactic dose and continue. Or I may give it for at least 9 months and then continue prophylactic and then stop. But it is going to be from patient to patient.
No, my question is, you have somebody with malignancy. It's not in remission. You've treated him with
Oh, not in remission.
Yeah. So you have to give anticoagulation.
Yeah,
You've given for 6 months.
yeah.
When you do a repeat scan, all the thrombus has cleared out.
I will continue
So
anticoagulation.
now, no, my question is what dose for secondary prevention? Would you continue with the therapeutic dose or would you cut it down to prophylactic dose?
If the cancer is active, and even if the clot has gone, I'll still continue with the therapeutic dose of the anticoagulation.
I think that's a very important point because people don't look at this part and they cut it down to a prophylactic dose and that's where you get rethrombosis.
Absolutely. I mean, that's the whole, exactly the point that you said, which is also I'm trying to make, that if the cancer is active, still need to give the therapeutic dose of the anticoagulation.
Showed was the use of anti-angiogenic factors for, I think.
But typically bevacizumab, I think those.
Yeah, exactly. But bevacizumab is increasingly used and it is also a cause of bleeding and perforation.
Correct, absolutely
So
correct.
here you have a contradiction wherein you are trying to treat with a either 10A or whatever, and there is a propensity for bleeding. So then how do you balance?
So typically these patients, when they're referred to me, I tend to use low molecular weight heparin because experience with low molecular heparin is much more. We know how to deal with the bleeding. The bleeding with DOACs, once they bleed, is difficult with
You
DOACs
have the
because there is no
antioxidant.
antidote per se. Same with low molecular weight heparin, but at least you can manage them with FFP. But for the DOACs, it's very difficult once they bleed.
I think
That brings
that's
me to that other question, because you said that, you would stop the DOACs 24 to 48 hours before surgery. Now, if you don't have an antidote out there, you took the patient for surgery, and there is no way to monitor it. I mean, you want to have a.
So right from the, thank you. So right,
half-life.
sorry, go on.
Yeah, go ahead.
So that's what I'm trying to say. Right from the outset, one needs to decide what would be an appropriate anticoagulant for that particular patient, depending upon the treatment that one is going to give and the surgery that they're going to do, what is going to be more appropriate. So if I would have known that this patient is going to have bevacizumab, I wouldn't have started DOAC in the first place.
I think the other factor that you also need to consider is what type of surgery. What is the risk of bleeding in that surgery? What's the renal function? Because that's how you decide whether you stop it 24 hours before, 48 hours before, 72 hours before.
there is a good scoring system for that as well. So you can balance off the risk of thrombosis with the risk of bleeding. I think that's been a very interesting and very interactive session. Thank you, Dr. Sameer, for taking us through the very, very interesting topic of cancer thrombosis. Thank you so much. We now move on to the next topic, which is acute limb ischemia, very close to the heart of all vascular surgeons. And as per the format, we start with a typical case presentation on acute limb ischemia. Dr. Prasanna Mokat will present a case, a classical case of limb ischemia, and then we'll have evaluation and diagnostics, surgical options, endovascular options, and we'll discuss the complications and failures thereafter. So Dr. Prasanna will start with presenting a case of acute limb ischemia.
Thank you, sir. I'm Dr. Prasanna Mokat, a third-year general surgery resident at Kokilaben Hospital, and I will be presenting a case on acute limb ischemia. So, my patient is a 59-year-old male who is otherwise physically active, non-diabetic, non-hypertensive. He was transferred in an ambulance from Matheran hill station nearby, nearly 80 kilometers from Mumbai. And he came to A&E at around afternoon, Sunday afternoon, with complaints of severe pain, which was continuous sudden onset on the right lower limb since morning, which was associated with decreased sensation and numbness. He was apparently all right around 7:30 morning when he completed his routine morning walk. After that, he started feeling numbness in the right foot around the toes. At first he ignored the complaints. He went on to the bed, and after 15-20 minutes, he started having sudden onset severe pain involving complete right lower limb, thigh, calf areas, which was, so he became restless and described it as he fell from the bed and had to be shifted to nearby hospital immediately. The complaints were not associated with, there was no generalized redness, swelling on the right lower limb or any features of cellulitis. There were no associated streaks of redness or swelling or any features of phlebitis. No history of any lifting heavy weight or backache. Were not associated with any giddiness or breathlessness. The pain was not tearing or ripping or not over a back area. Pain is not burning or deep muscle ache or any features of compartment syndrome. Not associated with any joint pain, swelling or fever or any features of acute gout-like presentation. There were no chest pain, sweating, palpitations, no weakness over right half of body. There was no pooling of saliva or difficulty in swallowing, no deviation of mouth or any slurring of speech, no history of similar complaints in other extremities or any redness, swelling in other extremities. It was not associated with any sudden onset headache or blurring of vision, no irrelevant talking, involuntary movements or any abnormal behavior. So no abnormal or strange sensation or sense of panic or impending doom. There were no abnormal smell or taste, no history of any injury to right foot or any scorpion or snake bite. So he was otherwise physically active, takes mixed diet, generally often eats outside oily street food, and he used to take morning walks recently. So he is otherwise a chronic tobacco chewer and alcoholic since last 40 years, and there was no similar family history. But he given history like last 2 months, he has pain on both lower limbs, generally after exertion or exercises, intermittent aching type in calf and hip areas. The pain used to get relieved on its own in 2 hours, and he never reported any difficulty in his daily activities or any disturbance in sleep. So in nearby hospital, he was given heparin 7,000 units intravenous stat dose around 8:20 a.m. and he was transferred from there to KDA-AH in an ambulance. On asking, he had given a past history. 7 years back, he had sudden onset pain on the left leg and associated with heaviness, inability to walk, which required hospitalization. That time, the presentation was 2 days from onset to presentation to hospital, requiring emergency clot suction procedure in cath lab. And since then, he is taking 2 oral blood thinners. And on checking the medical records, he had a left leg DVT with a left superficial femoral vein thrombus and stenosis of common iliac vein and IVC junction, which required suction thrombectomy, balloon dilatation, and stenting. On evaluation, he had a tachycardia, BP was high, and tachypnea, and otherwise pale and cold right lower limb, but not associated with any edema or cyanosis, no discoloration. There were no ulcer on pressure areas. Attitude was a restless right lower limb due to severe pain. And the right thigh, calf, and foot regions were cold. All peripheral pulses were non-palpable on right side, and the pain was aggravating on passive movements. The calf was tender, but there was no swelling or redness over the calf area. The sensation was completely absent in thigh and calf region, and knee flexion extension and ankle joint movements were reduced with the power of 3/5. Left leg and bilateral upper limbs were normal on examination with warm peripheral palpable pulses, no redness, edema or cyanosis, and no motor or sensory loss over other extremities. Other systemic examination were unremarkable with features suggestive of right lower limb ischemia, which was Rutherford class 2B with mild to moderate motor loss. Screening to DECO and ECG were done, so there was no arrhythmia on ECG and no motion abnormality or no blood clots on 2D echo. Patient was planned and underwent a peripheral angiography, which showed a complete, so this is a DSA demonstrating complete occlusion of right common iliac and external iliac arteries in the first picture, and in third picture showing a popliteal artery with complete occlusion, showing poor runoff in calf region. The tumor, the thrombus load was large, so immediately a surgical open thrombectomy decision was taken. Patient underwent early surgical revascularization with thrombectomy. So access over common femoral artery were obtained with proximal and distal control, and transverse arteriotomy was done. Thrombectomy was performed with proximal and distal thrombus removed. Immediately post-op period, the patient developed compartment-like syndrome features with calf tends and tenderness, calf tends and edema. So immediate fasciotomy was performed in right leg anterior, lateral and posterior compartments. In the early post-op period, positive DPA, PTA flow was restored on handheld Doppler. The patient was then shifted to ICU. The patient had a central line, so we did a CVP monitoring, and accordingly IV fluid was given started at 80 ml per hour, and accordingly adjusted. We kept a target of CVP of 8 to 9. The IV fluid was soda bicarb was added in IV fluids, and alkalinization was done, and simultaneously urine output was monitored, and if required, IV boluses or diuretics were given. Urine color and urine myoglobin urea was monitored. We had a drain kept, so we monitored the drain output and hemoglobin levels. Simultaneously, we did check for his wound for any hematoma bleeding. Simultaneously, clinically monitored his features of limb for any coldness, discoloration, or any sensory or motor findings. And we routinely monitored his improvement. Started slowly with passive physiotherapy at first, and then on to on day 2 or day 3 on out-of-bed mobilization. We simultaneously did a ECG at routine intervals to check for arrhythmias. We monitored his electrolytes for any hyperkalemia or features of reperfusion syndrome. So we did ABG every 4 or 6 hourly on the post-op day 0 and 1. We checked any lactate levels. We did a metabolic, monitored for metabolic acidosis. We monitored his RFT. And then we added analgesia. We continued fentanyl infusion. We added, after that, continued his IV antibiotics. And he was, just after surgery, started on its food after 4 hours. And after initial stabilization, he was shifted to ward. Meanwhile, we were continuing his wound care. And after that, he had an uneventful hospital stay. And he was discharged on post-op day 9 with complete sensory and motor recovery. He continued with physiotherapy at some time at home also. So serial follow-up was done at 1, 3, and 6 weeks, which showed a healthy wound at fasciotomy site at around 6 weeks. The patient was completely symptom-free, continuing oral antibiotic, anticoagulation, and the fasciotomy wound we did then later split skin grafting on fasciotomy wound after 1.5 months. So these are the pictures of 4 and 6 weeks post-op. Thank you.
That's a classical case of limb ischemia which Dr. Prasanna has presented. We now come to the next part, which is Dr. Harshvardhan Oak from Pune, and he will be talking on how one evaluates and comes to the diagnosis in such cases in clinical practice.
Good morning, everyone. So if you have heard him carefully, so patient was presented at 6:30 a.m. and 12 o'clock he was at KDH. So in reality, in real world, in peripheral parts of Maharashtra, it doesn't really happen. The reason being these acute limb ischemias, they are not diagnosed on time, or maybe we have become so much dependent on the investigations and angiograms and this. But I'll tell you something, acute limb ischemia is still such a disease that there are very clear-cut signs and symptoms. And if you pick up at the right time and right referral to the right specialist, it's a very worthwhile surgery and prevents morbidity, mortality, and amputation. And with the advent of anticoagulation, what I feel is many times primary care physician, they continue with 𝐬𝐿, and for first few hours you feel good, patient is symptomatically better. And then we lose that window of 6 to 8 hours. So still in today's world, many times we see a patient of acutely ischemia misdiagnosed with spine problems, orthopedic things, and came to us in a very late stage with fixed mottling, wherein we can do very little about those. So with this, I'll be just talking about the signs and symptoms, each one in detail. So as I said, in acute limb ischemia, your diagnostic clinical acumen, clinical judgment is a trump card. If you know the basics of the signs and symptoms of ALI, you don't need any other investigation. So many times as a vascular surgeon, if there is no time, if it's an impending compartment syndrome, we just go by our diagnostic clinical judgment and we take the patient for thrombectomy. So before going for clinical evaluation, I'll just go through the Rutherford classification. This is a very basic classification for ALI, wherein we divide these acutely ischemias into 3 categories. So category 1 is viable. Second category is threatened leg, which is divided into A and B. So to make it short, 2A means there is a sensory loss. So first category, you have only pain. You have few audible signals. So second category, in 2A, we have a sensory loss. 2B, we have a motor loss. So patient is not able to move the toes, etc. And the third stage, which is irreversible, when there is already a gangrene which is settled in. Many times you will come across this picture and you will be wondering whether it is labeled as acute, subacute, or salvageable or not. In the next few slides, we'll be seeing those. To make our clinical judgment more simpler, always you have to remember the etiology of acute limb ischemia. Either it should be an embolic or a thrombosis. So the first sign which we all should look at is pain. So anything, because not ideally every patient is going to come to you in 6 hours. So any patient who is having less than 8 to 15 days of history, leg pain, always you have to, first thing you have to rule out is acute limb ischemia, because many times I see everybody thinks in terms of DVT. And just start empirically 𝐬𝐿, primary care physician mainly. And nobody looks at the leg or checks for the pulses, and then we miss that acute limb ischemia diagnosis in early stage. So pain is always abrupt in onset, severe in embolic cases. Symptoms are usually unilateral, except in a rare circumstances where they can present with bilateral ischemia. Pain may be sometimes absent also. That also you have to remember. In diabetic neuropathy, sometimes there won't be that much significant pain. Or if it is already very late, if it's a dead leg, patient come with black leg, but he may not explain you or tell you about the pain. Muscle tenderness on palpation of the calf is a very important sign we should all look for. So 5 P's, the 6th P is also there, that we'll see in the next slide. So all these 5 P, you should always check: pain, pallorness, pulselessness, paresthesia, and paralysis. So pallor in early stage should always look at the limb. In a very, very early stage, the limb will appear pale due to incident spasm of the arteries. That spasm decreases over next 1 or 2 hours, and then the skin will have a reticular pattern. It will blanch on applying the pressure. As the time progresses, these blood clots, they start giving a dusky mottled appearance. Initially, this mottling is reversible, so that blanches on pressure. Still, you have a window of salvaging that leg. In a late stages, you get a fixed staining. Fixed mottling or fixed staining is a very bad sign, wherein we can classify that patient as a stage 3. And usually, these limbs are not salvageable. So the third P is pulselessness. Always we have to look for the pulses. The first thing, any patient, for that matter, who says leg pain, always his foot pulses needs to be checked, which is most of the time missed by the primary care physicians. So if pulses are normal in the contralateral limb, always you can think of an embolic pathology. thrombotic pathology, you will have both sides, the pulses will be absent. The fifth P is paresthesia. The main important thing is the loss of sensory function, which is in an early stage, as we saw the classification 2A. Initially, the patient will complain of loss of light touch, followed by vibration sense, followed by a proprioception, followed by deep pain and pressure sense. So when they lose a sensation, deep pain and pressure sense is lost. That's a very late stage. This helps in deciding the timing and choice of revascularization strategy. So if the patient still has only a loss of sensory perception, that is still you have a good window. So these patients still can be salvaged, the leg can be still salvaged. The loss of motor function, that's a fifth P, paralysis. So loss of motor function is quite bad. It shows advanced limb-threatening ischemia. Again, intrinsic foot muscles, they are the first ones to get affected in such things. So loss of toe movements, we need to see. Dorsiflexion, plantar flexion, again, that's a very bad sign. If somebody has a loss of dorsiflexion and plantar flexion, it's already a stage 3 almost. So if toe movements are preserved, still the leg is salvageable. The sixth P may not be always right because of most of the times these patients are anticoagulated at primary level. So intense vasospasm that can lead to a coolness and the legs are cool to touch. But then beyond the level of occlusion, but may not be right always because many times patients get covered themselves thinking that that will create more warmth. So it may not be always true. Talking about investigation, as I said, acute limb ischemia still holds true even in 2024 that acute correct clinical diagnosis can lead to a timely referral. But being in a tertiary hospital, you cannot just operate a patient in terms of medico-legal and other things or acute on chronic because many times these patients are already treated with anticoagulation in the past. Some collaterals are there or they may give a vague history of claudication, etc. in the past. So not necessarily patient will tell you the exact history. So in such cases, acute on chronic always needs to be ruled out because if it is not very acute and if it is subjected to embolectomy, then the results can be not so great. So always we need to investigate and see the level of occlusion or thrombus. So the basic general investigations, I won't be talking into detail. I think our hematology colleagues can throw more light on those. Prothrombotic workup, I feel if the patients are young, less than 40 years, gene-based and hereditary analysis can be always done. I think factor assess nobody does in acute settings. Most commonly, first choice is Doppler scan. It is very easily available, 100% sensitivity to detect the vessel occlusion. It identifies the level, severity, and chronicity of occlusion. But not always we get a very brilliant sonologist because many times we see that they give a very vague report and you're not in touch with that radiologist or you don't know him. And in reality, we see many times popliteal artery thrombosis being missed by radiologists and then we have done a CT angiography and found to have a occlusion. So there is always a limitation of duplex ultrasound. Until unless you have a team with which you interact every day, you can rely on duplex ultrasound. Otherwise, the best investigation is to do a CT angiogram, wherein we don't rely on anyone. It's a direct 3D reconstruction images you get within 3.5 minutes. Highly sensitive, highly specific. You get a 3D image, you can see the collaterals. If patient has been already operated in the past, you can see his bypass grafts, stents, etc., or the calcific segments. And it is done very quickly. So CT angio should be the first investigation of choice if creatinine is normal. So again, we coming back to the classification. Again, always after all this evaluation, still we have time to salvage the leg. So always, all this clinical evaluation is very important in deciding and classifying these patients. Thank you very much.
Dr. Harsh, that's a nice talk. One quick question and a practical question. On which class of patients you suspect a case with acute limb ischemia? in which case of what type of patient would you proceed to a surgery or an intervention with just a Doppler, and whom would you wait, do a CT angio? Because very often we find that the patient is getting referred saying actually I had sent him for a CT angio and it was getting done and we lose a couple of hours. So who would be the patients? Would you be comfortable operating with just a Doppler report, or would you want a CT angio in all cases?
If he has crossed 6 to 8 hours beyond his first the time of onset of symptoms, number one. Number two, if it's an impending compartment syndrome or already a reversible mottling, if you can see, then I think it's better to go ahead immediately. If we should not waste the time in CT angiogram. I think class 1A of 1, where there is only pain and you have hyperenized, the leg is soft, so you have the time to do a CT angiography. Depends upon that center, because every hospital or every consultant may not have access. Sometimes we see that CT angio itself takes few hours and then that window is lost. So
valuable
probably
time is lost.
Yeah.
Any other? Yeah.
Presented with pain and so looks like this patient already had previous surgery, right? And the gentleman presented. So then, it cuts the chase because past history of claudication, you have a surgery over there. There is something in that limb.
Yeah, he's a
that is going on,
prothrombotic
right?
kind of.
You had this long history of snake bite and scorpion. I mean, those were irrelevant kind of thing. You have to come straight to the point that this is something related to the limb. And the CT angio takes a very short time. It doesn't, if he's in the right place, that can be done, because especially in elderly people where you have chronic issues like embolic versus another thrombosis, whether an embolectomy just would suffice or not, is the question. Here you would probably take in for CT angio, and then, I don't know whether that patient required just crossover fem and a fem pop or whatever. So the reason I'm telling is a lot of time gets wasted in doing ancillary.
In the index case that was shown, the previous was a DVT and not an arterial thrombosis. Now, what we want to highlight is,
that was also not clear to me whether he is presenting a venous issue.
he had an acute DVT which was treated, thrombolized, and he had an iliac vein narrowing, he had a stent, so he was on Novax already. The point we want to highlight is, despite Novax, he's had an arterial, so he's had a venous followed by an arterial thrombosis. So that is something which can happen and we see quite often. And the approach to somebody who's had a venous, one episode treated on Novax, and now having an arterial thrombosis, this patient is presently on warfarin. And is. No, it was mentioned as a common iliac vein. So the first attack was an acute DVT for which the common iliac vein was stented, and then he was put on Novax and aspirin. And despite that, he's had an arterial thrombosis, which means that just because you're on a Novac, it doesn't give you a kind of an insurance to getting a thrombosis. That there will be a subset of patients who will need warfarin rather than Novax, right? So it's not that since the Novax are there, the warfarin, and we'll discuss a lot of it in our course. Yeah, we will discuss that. I think Dr. Advait Kothurkar is one more expert from Pune. Yeah, yes, sir.
Both venous and arterial thrombosis. Do we know the reason for the events? I mean, have we investigated, say for example, lupus anticoagulant, hyperhomocystinemia? Nothing was found.
In your talk, but very often we do all the tests saying that he has venous and now arterial, and we come to not. So how do we approach that? We'll discuss that in maybe when you give your talk. I think Advait can go forward. Yeah.
Yes.
Thank you, Dr. Shekhar, for inviting us for this talk. I'm going to talk about the surgical options that we have in acute limb ischemia. Now, what I would like to reiterate is that these 6 P's that Harsha talked about are very important for you to use clinically, because if you've got a patient with a wide cold limb, the commonest thing is that the pulses are not palpated. And this is something that could end up causing a patient an amputation. By the time the patient develops paresthesia and paralysis, the boat may already be at a point where you can't do much about it. So please try to keep that in mind. So now, why is it an emergency? Once the oxygen supply to the limb is shut off, it sort of starts a fire there. There are a lot of inflammatory mediators which start off cytokines, prostacyclins, and oxygen-free radicals, which cause a lot of damage to the local cellular tissues. And then if it is left untreated, it progresses to a systemic stage as well. So we do not want to let all this endanger the patient's limb and eventually maybe the patient's life. So it is a kind of an emergency. ALI has a high risk of morbidity and mortality. 50%, up to 50% mortality has been documented because of associated comorbidities in these patients. Muscle death starts within a couple of hours and may be reversible by 6 hours. So we've had patients who have been trying to come from Aurangabad to Pune, and by the time they reach Pune, the limb is already gone. As muscle death occurs, the risk of reperfusion injury goes up. So injury which is, sort of, this problem with ALI is that first, it's like you do not get any blood supply at all. And then once we reperfuse and start the blood flow again, then you've got a lot of blood supply which causes a reperfusion injury. So I suspect one of the other speakers is going to talk about reperfusion injury. But that is something that all of us worry as vascular surgeons when we are operating. In cases of irreversible ischemia, sometimes an amputation is much better than reperfusion because of this reperfusion injury, which can sometimes, take life while you are trying to save the limb. So that should not be done. The problem in India that we see is delay, delay, and delay. It is very unusual for somebody to reach a hospital within 6 hours. Most of the times we get such delayed presentations that even although we can do a lot of things, not much can be done for that particular patient. And this is how they present with advanced limb ischemia. So what would you do if you get a patient of ALI? I would say call up a vascular surgeon even in the middle of the night. Most of us are doing something or the other, are awake. So just give us a call and we will pick up your call and try to start treating the patient. Okay, then you start with unfractionated heparin. Why unfractionated heparin? It's probably something that is a shorter acting anticoagulant. The second thing is, in the worst case scenario, you can reverse it with protamine. So you can start off with a loading dose of 5,000, that is what is usually recommended, and a drip of about 1,000 units per hour. Let us know, contact us, let us know the comorbidities and the current state of the limb, especially sensation and movements. That's what we ask all our residents in the middle of the night, are there sensations and movements? And dispatch the patient or call your vascular surgeon to your hospital as soon as possible. What do we do? So we sit back, prepare and wait. We keep the operation theater ready. We alert the anesthetist because although it can be done under local, it is better that because of the comorbidities, if there is at least an anesthetist on standby. The CT angio, like Harsha said, is getting done and we are trying to think about what is going to be done next. So what we are thinking about is more or less with acute limb ischemia, is it embolism, is it thrombosis, trauma? Of course, we will get the history. So this is how acute limb ischemia is, embolism or thrombosis. Now, for acute embolism, you usually have a cardiac source or a proximal source of thrombus.
So you can have a thrombus in, say, the left atrium because of a patient with atrial fibrillation. You can have a patient having a transmural myocardial infarction and a left ventricular clot which embolizes down. You can have rheumatic heart disease. You have thrombi sitting in the arch of the aorta or the descending aorta, which can embolize down into the limbs. You can get aneurysms which have thrombosis as a protective mechanism, and that thrombus can embolize down. Also, obviously, trauma. So what we have to realize is that the thrombus or the clot has come from another source and is sitting in a relatively normal artery. What is in situ thrombosis is, you have to think about it as there is a diseased artery which has a plaque, and this plaque has given way, it has ruptured and caused thrombosis there. Usually these patients are arteriopaths, dehydrated elderly patients who may be on vasopressors, sepsis, etc. We have to deal with the acute element and the chronic element, because sometimes you get the acute clot out and you still do not have a flow which is established. So they may require another procedure. Clinically, if you see these patients, they are not as desperately bad as the embolic patients. Embolic patients tend to be desperately bad because these patients have some preformed collaterals because of the chronic disease. So that's what gives us some time, and that could be a reason why you would want to do an angio in such patients. So there is always a clinical conundrum. Is it embolism? Is it thrombosis? So as a vascular surgeon, what we need to do is we need to have our strategies planned for either way. There are some pointers which will tell you what is happening there, but still you can never 100% be sure. Trauma, of course, is a different situation. Just because it was ALI, I have included trauma a few slides. But in trauma, we may have to deal with bleeding and ischemia. There may be other organ injury. Other specialties may need to be involved, and principles need to be followed, like life over limb. So with non-traumatic ALI, the first thing that once we have got everything in hand and the patient is in the operation theater, the first thing that we do is to do a fasciotomy. What I think the fasciotomy does is you can assess the muscle viability. Most of these patients will reach us late. You've got some paralysis of the toes. You don't know whether the muscle is viable or not, and you do not want to revascularize ischemic, severely ischemic or a dead muscle because of the risk of reperfusion. So you can assess the muscle viability, and later on you can also treat the compartment syndrome that develops. So in that patient, when we saw, what I would have thought is, I do a small fasciotomy at least to start off with, look at the muscles, and at the end of surgery complete the fasciotomy. And then you proceed with an embolectomy or an amputation. I also tend to record these patients. So those patients who are going to end up with an amputation, I take a video of these patients' fasciotomy being done and the muscle, whether it is viable or not. So then when we decide to proceed to an embolectomy, what are the common sites of access? In the lower limb, the femoral, of course, unilateral or bilateral, and in the upper limb, the brachial is the commonest site of access. And I think this is a device which has really changed the treatment of acute limb ischemia. Before this, I think you would have had to go down to the site of the thrombosis. It may be somewhere in the abdomen and you want to open that up. It means a major surgery. But this is a Fogarty catheter. It's like a Foley's, but stiffer and a bendable tip. So you put this Fogarty down through the artery, across the thrombus, and then you inflate that balloon and it just simply pulls out the clot along with it. So this is what the Fogarty catheter does. So from a remote site, you are now actually able to access a thrombus at a proximal or a distal site, which may be difficult to access. So it is still a limb saver in open surgery. And now you've got modifications of that. So you've got over-the-wire Fogarty catheter. So with introduction of the hybrid labs, in which I think Rohit will be talking about. So you've got a wire which can be put down, you've got a Fogarty over that, and you can pull out specific clots from the areas. You've got Fogarty catheters for grafts. So these are sort of tougher clots to take out. So you've got different catheters, but essentially modifications of the same catheter. What is important now, the principle is that once you are doing the embolectomy, the inflow and the outflow need to be satisfactory. So you have to establish that there is a good inflow which comes only from experience, and the outflow and the back bleed from the artery you have to assess that. If you do not get inflow, that means something proximal is still happening. Like Dr. Pai was talking about, there may be a dissection or something, which if you have not done a CT, you wouldn't know. But you need to think about whether you need to go somewhere else proximally for getting a good inflow. Complete the fasciotomy if necessary. Check pulses after closure in the OT. In the OR itself, you would want to check the pulses. And if you've done an embolectomy and you expect the circulation to come back to normal, your pulses should come back. You can wait for some time for spasm, but otherwise it should come back. If it does not come back, something's not right. You can do a completion angio, which even with a C-arm in the OT, you can on table put in a tube, flush in some contrast, and you see what's happening there. And if you need to, you should re-explore that there itself. There's no idea in taking the patient back to the ward and then shifting him back in 2 hours. Let's jump over that slide. Acute in situ thrombosis is something where now you know that your embolectomy may not work. So if you have guessed correctly preoperatively, then you need to think about in situ thrombosis. So the second thing is, if you have done an embolectomy and your limb is still ischemic, you think that something else is happening, there is chronic disease which is seen on the angio, then you're thinking of acute in situ thrombosis, where we have strategies now with the endovascular stuff that we do. But what I am talking about is restricting myself to open surgery. Rohit will talk about the endovascular stuff. So if I had no endovascular experience or no cath lab available, the next thing that I would do is, if I have not got a good pulse back, I would go back and try to do a bypass or an endarterectomy, take out the chronic clot, treat the chronic lesion, and then get my pulses back. So something like this, you do a bypass in the leg and the upper limb. So that patient who had an embolectomy, we did a bypass from the brachial to the radial artery. So you have anatomical, extra anatomical bypasses where depending on the patient fitness, you decide what you want to do. So hybrid operation theaters are now a boon to the vascular surgeon. All interventions, whether it is open, endovascular, can be done in the same room in sterile environments. Trauma, I will just briefly go over. You can get external trauma like this or internal trauma. And the principles remain life over limb. So that is important to remember. Control bleed with pressure as necessary. Adequately resuscitate the patient. You may need multi-speciality involvement. You may need rigid bony fixation. So you get a patient with a fracture and an arterial injury, you would want rigid bony fixation. Ideally, if you have enough time. If not, you can put a temporary shunt in. You can get secure, so at a point of bleeding, if you have, you need to get secure proximal and distal control. And as vascular surgeons, even after we've got control, you would still put a Fogarty down and clear the distal circulation. I've seen patients who have been treated by other specialties where they have not put a Fogarty distally, they have repaired the artery, and the distal circulation doesn't open up because there is a clot which was there, which was sitting there and was not noticed at all. Iatrogenic trauma again is on the rise. So we've seen the first patient is a patient who had Boveran injected into her brachial artery. So we lost that limb, and then now we have more angios which are being done fairly routinely. And the last one is about a knee replacement which ended up with a popliteal artery injury, which we had to repair because the leg was ischemic. Principles still remain the same: proximal distal control, repair the artery, get the blood flowing back. So in conclusion, what I would like to say is, a patient with severe pain, with a cold limb, do not forget to feel the pulse. Diagnose early and contact a vascular surgeon. Do not waste time in complicated investigations as were discussed just now. Count the duration of ischemia in hours, don't let it go to days. And a timely referral can prevent an amputation for your patient. Thank you.
Thank you, Dr. Advait. Any questions?
Yes, I mean, you could do it if you had the facilities. What I tend to do is, I by default tend to, because most of our patients in our experience come late. I mean, in Mumbai, most of our patients will present to us late. I think in Mumbai, you may have a faster referral, but in Pune, most of the times it is about 12 to say 18 to 20 hours of delay at least. So I have a very low threshold for fasciotomy. I just open up the compartment. Initially, what I do is I do a subcutaneous fasciotomy or a smaller fasciotomy, look at the anterior and posterior compartment. If the muscles look viable there, then I proceed with the embolectomy. And then once the embolectomy is done, then I open up the compartment, assuming that it is going to swell.
You have intracompartmental manometers, but they are hard to get.
Yeah,
So
they are
generally
hard
the
to
rule
get.
we follow is that if compartment syndrome crosses your mind,
Yes.
go ahead and do a fasciotomy. You know, if it crosses your mind, is this compartment or not, it's better to go ahead and do the fasciotomy rather than err on the wrong side and say, no, maybe it's not, and delay the fasciotomy. There's no harm in actually doing a fasciotomy and finding that everything is good. You know, there's no harm in that.
There's no harm.
Sometimes it's a morbid procedure, as you can see, and
Yeah, but-
doing a 3-compartment is like.
But if you have facilities for a manometer, nothing like it. If you don't have facilities, go by your gut feeling. There's no harm. It doesn't add that much to the morbidity. Yes, it does, you know, give you scar. But when we do the consenting for acute limb ischemia, we consent for a fasciotomy as well.
Absolutely.
The fact that you'll need a fasciotomy and that you'll need to close it later on as well.
Absolutely.
That's the consent part of the consenting, which is a very important aspect actually, which we've not touched. How do you consent for a patient for acute limb ischemia? You know, that we say that we hope for the best, but you also prepare for the worst.
Yes.
Thank you. I think we'll go to the next speaker very quickly. Dr. Rohit Gupta has come all the way from Nagpur, and he's a consultant vascular surgeon in Nagpur with his own setup. And he'll be talking about the newer ways of treating acute limb ischemia, endovascular.
Good morning, everyone. Thank you, Shekhar sir, for inviting us for the talk. So, endovascular treatment options in acute limb ischemia. I would like to take few points from Pai sir's talk today morning when he told that things look different when we have different viewpoint. Like Galileo had said that Earth is not the center of universe, and Earth revolves around Sun. So when he told that thing, at that particular time, society boycotted him because his view was different from everyone. And that's how, when I'm talking about endovascular treatment options, earlier, as a surgeon, we never were interested with catheters, needles. It was not surgeon's thing. As a surgeon, when I completed my training, most fascinating was oncosurgery, where we were trained to open from head to bottom. Everything you open, the more bigger in the incision, you are more thrilled and fascinated. So I was, in 2007-8, I was in Mumbai, Tata Memorial as a surgical resident. When I got first exposed to this endovascular things. We had received few patients who had GI bleeds and carotid blowouts, for which we have to take them to endovascular suits for repair. And that's how it fascinated me, ki this is something different and we should take this as a career option. And that's how I got into the course and pursued it. And fortunately, till date, I am passionate about what I am doing. So to start with, again, goal of endovascular management is rapid clearance of clot and restoration of arterial perfusion as early as possible to prevent all the complications what were discussed by the previous speakers. So basic principles remains the same. See, basically you have to wisely choose your patients, risk assessment for bleeding, because we might be using thrombolytics, blood thinners. So risk assessment is important. Level and nature of thrombus can very well be assessed on Doppler. We as vascular surgeons are trained in ultrasound Doppler as well. So we do have Dopplers in our own clinic OPDs. We see if at all thrombus is acute or chronic. See, if at all thrombus is acute, it will appear as swollen thrombus. Artery will appear larger than the usual size. Whereas if at all this is acute or chronic, then you can identify calcified artery over which there is some thrombus. So there is already a narrowing in the artery on which a thrombus is there. So that's an acute on chronic. You need to plan your access site. Again, Doppler helps in it. And nowadays we take Doppler guided puncture, which prevents further complications. And definitely you should have proper endovascular hardwares which can give better results. So these are the three major groups which we use to revascularize. First is catheter-directed thrombolysis. Second, mechanical thrombectomy. Third is pharmacomechanical thrombectomy. I'll just go through them in later slides. To start with, first one is catheter-directed thrombolysis, in which we use fountain catheter. That catheter is placed from a distance, I suppose a common femoral artery, and we want to thrombolize on the opposite limb. We can take that catheter from opposite side to the index limb and then place catheter intra-arterially in the thrombus and start thrombolysis. So this is preferred treatment for viable or marginally threatened limbs belonging to class 1 and 2A, or acute thrombosis of any native artery. Maybe it can be acute or chronic, or patients with previous bypass grafts or stent thrombosis. In all these patients, we can use this treatment options. Again, as we all know, indications and contraindications, major and relative contraindications for using of thrombolytics. Most important are if at all patient had previous history of cerebrovascular accidents in last 3 to 6 months, or any head injury or spine surgery. These patients should be avoided, or if at all he or she is having active bleeding disorders. So these are the common thrombolytic agents what we use for treatment of acute limb ischemia patients. Altiplase, retiplase, and tenecteplase. Most of the studies for peripheral limb ischemia is done on altiplase. Two regimes are there, either a low dose regime or a high dose regime. It depends on thrombus load, what regime we will opt. Usually for lower limb, we go with low dose regime, which is 1 milligram bolus, 1 or 2 milligram bolus RTPA is given at the site, followed by 0.5 to 1 milligram per hour of infusion, which is continued for 10 to 12 hours. Next day, patient is again taken to cath lab for check angiogram. While patient is on thrombolytics, he needs to be monitored very vigilantly, especially for neurological symptoms. When it comes to blood tests, we monitor it by serum fibrinogen levels every 4 hours. Usual normal fibrinogen levels are around 200 to 450 milligrams per deciliter. But if on thrombolytics, if their concentration decreases by 50% or comes below 100 milligrams per deciliter, then there are high chances of bleeding, and hence thrombolytics should be stopped. All these patients have heparin infusion through the side port of sheaths to prevent patency of sheaths. So advantages of CDT are that direct delivery of drugs are given into existing thrombus, and thus it reduces dose of thrombolytics used as compared to systemic thrombolysis. It can be used for both large as well as small vessels. Lower incidence of reperfusion in the case, slowly it reperfuses, but there is a flip side of it. If at all this thrombolysis goes unsuccessful, that might lead to more ischemia and dreaded complications. So that's the disadvantage of it. And there is high risk of major bleeding as well. Factors affecting successful intervention depends on whether this clot is new. As I mentioned, if at all there is acute thrombus, it will have a better prognosis as compared to subacute or chronic, which is more than 14 days old. To help that, we can have a guide wire traversal test. We usually pass a Terumo guide wire through the clot. If at all it successfully passes very easily through the clot, it suggests clot is fresh and will have a better outcome. Third is, if at all patient is old, diabetic, having different comorbidities, atherosclerotic risk factors, then there is chance this might be a acute on chronic type of thing where we might need some additional procedures for successful revascularization. So as I mentioned, these are the other factors. One main thing is when we are dealing with patients who had undergone bypasses using prosthetic grafts, their success rate is low because of neointimal hyperplasia at the site of anastomosis. So usually these patients after thrombolysis will require an additional procedure in form of stenting to keep these grafts patent and flowing. So after CDT, dreaded complication is an intracranial hemorrhage or minor hemorrhages from any other sites. Other complication is compartment syndrome after reperfusion. This may occur in 5 to 25% of cases, and one should be very vigilant if at all a patient develops a reperfusion syndrome. You might need to act fast. He might require fasciotomy and renal flushing so that there is less risk of renal injury, which may occur in 15 to 20% of patients. These are the few trials, University of Rochester trial, STYLE trial, TOPAZ trial, which gives evidence, enough evidence that CDT works in patient with acute limb ischemia. From STYLE trial, we concluded that patients who are presenting within 14 days of initiation of symptoms will improve with CDT, and those who are coming beyond after 14 days may be benefited by surgical procedures. Again, TOPAZ trial gave us information about use of thrombolytics, which can give decent comparable result to the surgery without increasing complications. Now coming to second subset of devices, which is mechanical thrombectomy devices. These devices rely on fragmentation of thrombus and along with it simultaneously aspiration of thrombus to restore arterial flow. So there are three types of mechanical thrombectomy devices. Aspiration devices, which simply aspirates the thrombus. Mechanical or rotational devices, which will macerate this thrombus. And third are hydrodynamic devices, which will, through a high-speed water jet, saline jet, will macerate clot and then can be absorbed. This is a Cleaner XT device. This is a rotational mechanical thrombectomy device, which is a handheld battery-operated unit. Cause an it is having sinusoidal wire at the tip, which rotates when we start it, and thus macerates the clot. Angiojet thrombectomy catheters, these use high velocity water jets enclosed in catheter. It utilizes Bernoulli's principle for capture, microfragmentation, and removal of clots. This is a suction device, aspiration thrombectomy device, Penumbra, which is basically a suction aspiration device and removes fresh clot emboli through these blood vessels. We faced a few problems when we were using these devices, Penumbra device. We faced that there was blood loss in patients because there was no control. Whenever we were in patent lumen, we lost quite a few blood. And when we come in thrombus, repeatedly, catheter was getting blocked. So this problem was solved by AI. So now we have AI system in thrombectomy devices as well. So this AI thing helps in differentiating between blood clot and blood flow, thus minimizing blood loss. And there is a valve which has been orchestrated to maintain negative vacuum force and thus giving optimal pressure to suck the clot. Third category is pharmacomechanical thrombectomy, where which has advantages of both mechanical as well as chemical thrombectomy. So here mechanical clot is removed after giving thrombolytics. So there are two such devices. 𝐬𝐼𝐳 device, which uses ultrasound for better RTPA penetration, and second is angiojet. So we do have evidences for this machines, these tools as well. Dutch trial has demonstrated that ultrasound accelerated thrombolysis had better results than simple CDT. So although we don't have this particular device in India, we are not using it. Instead, we are using angiojet thrombectomy system, which is basically first we use pulse spray mode to instill RTPA into the thrombus. We wait for 15 to 30 minutes for this RTPA to act on thrombus, and followed by it, that is aspirated. So this is basically pharmacochemico-mechanical thrombectomy. This, out of all these systems, this acts best and fast, and gives better patency rates. So Pearl registry had supported the treatment given by PMT and angiojet. So its advantages are that it disrupts the thrombus, allows better penetration of clot by a thrombolytic agent, reduces thrombolytic dosing, reduces therapy time. As therapy time is reduced, it can be increasingly used to treat patients with in class 2B ischemia. But major disadvantages are expensive. These devices are expensive and cost. So as Dr. Advait told, hybrid procedures, if at all patient is having acute on chronic ischemia, then these patients require to be taken in cath lab. We can offer them initial procedure as surgical embolectomy and then take a check run. If at all there is some underlying disease, suppose there is some plaque or critical narrowing, we can offer them balloon angioplasty or stenting. So a hybrid cath lab is important for vascular surgeons to give better results, especially in patients who are old age, and having associated atherosclerotic risk factors. So this is an algorithm for acute limb ischemia patients management. If at all patient is having class 1, class 2A and 2B, now we can offer them endovascular options first if patient choose to be. Will have equally good results without having any increase in number of complications. So there is one case when we did last month, a 69-year-old obese female from Calcutta. She underwent bilateral TKR, and post-procedure in evening round, orthopedician felt that her limb is cold. He immediately called me up, what's the issue? Can you check it? We had a CT angio done, which was showing thrombotic occlusion of right popliteal artery with no distal reformations. So there was no distal reformation seen. But as patient was old, obese, we were expecting it to be an acute on chronic thing, which has worsened during surgery. So we had given her both the options. We can do a surgical embolectomy, or we can go ahead with a minimal invasive thing. She opted, already I had a surgery. We want a minimal invasive thing. But still I counseled that it's okay, we are doing minimal invasive thing, but because arteries are small and distal disease, we might need a hybrid type of thing. We went ahead to do a penumbra thromboembolectomy. These were the initial pictures. We can see popliteal artery was blocked, and slowly we could retrieve all these clots through penumbra embolectomy devices, and ultimately could achieve good distal flow, which we were not expecting because we were expecting it to be full of thrombus. Fortunately, we got through. So to conclude, for a surgeon to be talking about endovascular thing, it's really fascinating thing. So we should be having a careful arterial access, and we should plan the procedure, how you will access, what you are doing. You should be ready with your plan A, plan B, plan C. If at all something goes wrong, you should have a fallback option. Judicious use of thrombolytics to prevent bleeding complication is important. Nowadays, with more and more new gadgets coming up, endovascular options are becoming safer and effective. But careful case selection is important, and planning is the key to success. Most important thing is clinical outcome is more important than the radiological one. So as a vascular surgeon, we never see that whether this stenosis is there and this needs to be treated, unless and until it is very important and critical. So treat patients, not images. Individualized approach to limb salvage is important, regardless of ischemic class. One last point which I want to emphasize is, when we discuss whether open surgery is better, endovascular is better, we always have that conflict, which one is better. But I'll say these are not competitive therapies. These are complementary therapies which should be used judiciously to give best result to our patients. Thank you.
Thank you, Dr. Rohit. I think that makes the subject pretty clear. But all procedures, may be open or endovascular, have their own complications. And I think the next speaker, Dr. Vineet Paliwal, will talk about how one manages, how can one prevent complications while treating limb ischemias.
Dr. Shekhar. Yeah. Only one, in this water jet therapy, that is mechanical thrombectomy, how do you have a distal control? Because there is always a possibility of further emboli going down.
Yeah, that's a good question. Actually, there is always a danger of that happening.
Distal control. So you put a Fogarty's through the femoral. you have a, say, a popliteal block, all right? You're doing a mechanical thrombectomy. Penumbra is the ultimate combination of everything. So that is the final tool which you have. But you spoke about water jet type of this thing. So when you have that, there is always a possibility of those migrating downstream, which will then be irretrievable.
See, that is a complication which he'll discuss, but the whole principle of an angiojet is based on what you call a Venturi effect. So there is a spray, but as well as a powerful suction as well going on hand in hand. So if you're trained in it and you know how to use it judiciously, you can minimize this complication. The problem is that it's used many times in untrained hands. It can be lethal and it can just worsen the ischemia.
Exactly. For that, you can always use a distal embolic protection device. If at all you have a distal single vessel runoff, which is an important artery which will be salvaging limb. If at all you're seeing that, first of all, you can anticipate it and place a distal embolic protection device. After that, do embolectomies, and over-the-wire Fogarties are available, which can be used and selectively. So you have to mix and match all the therapies. This is armamentarium, what you have. You have to choose wisely, depending on patient factors, and that's how.
Which is why when you know, the point I'm trying, and he's trying to highlight is, end of the day, you need to send your cases to a guy who knows how to manage the complications as well. I think you listen to this talk, you'll know that the guys who do this should be the guys who know how to manage the complications as well. Not know only endovascular, but you land up in a soup. See, it's not good enough to know how to do just a laparoscopic cholecystectomy. If you injure the bile duct, you should also be competent to do a hepaticojejunostomy. Same way, if you send your cases to a vascular surgeon, if there is a screw up, they are competent enough to salvage it as well. You hear the complications, I think Vineet will highlight how you can minimize the complications of vascular procedure.
No, sir.
Yeah.
I'll not say, we as vascular surgeon, daily, day in, day out, we are dealing with blood vessels. We don't find that once, even some days are like that, if at all there is no outflow, we use thrombolytics while operating. You tend to infuse those thrombolytics in disturbance, so that vessel runoff should be there. So that we can check on hybrid suits. So that is important. So once you are finishing job, it should be done in a one go. Our main motto is do best job in first time, rather than doing a catching up job. That's the best. Whatever you want to do it best in first job, first go.
Hello everyone, I'm Dr. Vineet Paliwal. I'll be talking on acute limb ischemia, failure and complication. Actually, my topic was complication and failure, but I have twisted a bit to, I think if we can reduce, means if we can manage case successfully, then there will be less complication and we'll be having good prognosis. So most of the points are covered, but I'll try to sum up. So acute limb ischemia, we know what it is and the causes. So incidence is around 1.5 cases per 10,000 per year. So though after revascularization also there is a high complication is in ALI. So 30-day mortality and amputation rates are around 10 to 15%. So it is important to understand reasons of failure and the complications to reduce mortality and morbidity. So failure and complication, they follow each other. So if there is a failure, will be more complication and leading to poor prognosis. So to assess the reasons of failure, I have categorized into this 4 segment: failure due to delay at various level, failure due to assessment in clinical assessment, failure due to unable to understand pathophysiology, and operator bias, means operator choice or failure at operator's level. So Delay in diagnosis or misdiagnosis is due to unfamiliarity with the clinical presentation, inadequate and history taking and risk factor analysis, inadequate physical examination, which nobody does, limb examination, pulse palpation, and neurological limb examination. Failure to include ALI in the differential diagnosis, mimics of acute limb ischemia like spinal pathology or neurological pathology, delayed consultation by patient, delay in starting anticoagulation or the primary treatment, delay in referring to vascular surgeon, delay in decision making or obtaining consent, delay in logistics like preparing OT, cath lab or getting equipments. So to avoid this, we need something like cold limb or acute limb code to fast track this process and early for the better outcome, early revascularization. In assessment, we have seen this chart, Rutherford classification of acute limb ischemia, where class 1, 2, 2A, 2B, 3, where in class 1, the limb is not immediately threatened, so we have days to revascularize. Class 2A, marginally threatened, so we have to revascularize this patient within hours. Class 2B, immediately threatened, so this patient needs to be revascularized immediately. So in such conditions, we cannot do CDT, which takes 12 to 24 hours. So that's how we have to assess the patient and plan treatment modality. Class 3 is irreversible ischemia, where we should not attempt revascularization. Straight away, primary amputation is needed. Failure to assess comorbidities and other investigation like 2D echo, blood parameters, general condition, urine output, kidney status, blood gases like acidosis, lactate, CPK. So again, pathophysiology. So these are the causes of acute limb ischemia: embolism, thrombosis, acute on chronic limb ischemia, peripheral aneurysms, dissection, aortic dissection, trauma, iatrogenic, hypercoagulable state. So this different pathophysiology has different causes, and we have to treat according to pathophysiology. So one treatment modality doesn't suit for everything. So in upper limb ischemia, cervical rib is important. So in upper limb ischemia, we have to look for cervical rib, and we need to address that. Raynaud syndrome can present like ALI. So mostly management is medical management in such cases. So next is operator bias. So there are some operators who can do only intervention or endovascular treatment. There are some operators who can do only open surgery, but there are few operators who can do open endo and hybrid procedure as per the need. So I'll go through some cases to highlight, to clear these points. So this is acute limb ischemia, where we opened took open femoral access, and angiogram show there is a occlusion at popliteal and tibial levels. So all three vessels are occluded almost. So we did over-the-wire Fogarty in cath lab. So we could achieve all three, we could do embolectomy in all three vessels, and anterior tibial, posterior tibial, we could clear with Fogarty catheter, and completion angio, we can see all three vessels are flowing good. This is important. Doing blind embolectomy, we can miss complete clot retrieval or the revascularization. Trauma case where axillary artery injury was there, and CT angio shows there is, I think, discontinuation, pseudoaneurysm, something has happened in axillary brachial region. So doing endovascular treatment here is not good option, like stenting or anything. Doing blind embolectomy will not help. So I have done here axillary to brachial bypass with good result. This is again brachial artery injury. So most of the trauma cases causes endothelium injury. So in this condition, embolectomy or the CDT or suction thrombectomy doesn't help. So I have done here interposition grafting with good result and palpable pulses. This is different pathology, popliteal artery aneurysm causing acute limb ischemia. So again here, resection of popliteal aneurysm, FEM PTA bypass with good result. This is interesting case. RTA, tibial fracture, tibia fracture. CT angio shows radiologist reported there is a spasm at popliteal level. So orthopedician took patient for external fixation. After external fixation, limb was cold. Fortunately, he examined and limb was cold. So he gave call to vascular surgeon. And on exploration, I could find there is a popliteal artery transection. So that damaged segment I have to resect, and I have to do end-to-end primary anastomosis. So every case is different. So we, before choosing approach, we need a holistic approach to decide therapeutic strategy. Strategy depends on the type of occlusion, type of location of occlusion, type of conduit, Rutherford class, duration of ischemia, comorbidities. And so these cases should be treated by doctor or surgeon who has the ability to diagnose, assess, and give proper option or the option for the treatment. So one should be well versed with open surgery, endovascular intervention, hybrid procedure, and post-op medical management. So one should not run after intervention that my job is done. So after revascularization, we need to keep patient in follow-up for further prevention of such attacks. So again, so if we can reduce this failure and we can manage success, then definitely complications will be less. So to enlist the complications are major, minor amputation, reperfusion injury, compartment syndrome, sepsis, DIC, ischemic neuropathy, myoglobinuria, rhabdomyolysis, renal failure, bleeding, hematoma, pseudoaneurysm if access is not good, surgical site infection. So major and important complication is reperfusion injury. It's a complex inflammatory response and may cause further injury to the tissue leading to multi-organ failure. So here treatment is mostly supportive. Again, I'll go back and say if we can avoid, to treat reperfusion injury is to avoid reperfusion injury. Means according to the class of Rutherford ischemia, we should assess and revascularize or ampute. Again, reperfusion injury can be avoided with controlled reperfusion. So controlled declamping can reduce reperfusion. Bloodletting, I don't know, there is no enough evidences for bloodletting or the phlebectomy. Antioxidants, hyperbaric oxygen, all are other few strategies. So again, compartment syndrome, we have just a big discussion on compartment syndrome. So it is a tense, painful muscular compartment. It's clinical diagnosis. Once it crosses the mind, you should go ahead and do the fasciotomy. So as Kothurkar sir said, we almost if there is a doubt, we do small fasciotomy and decide muscle's viability and go take it further according to the muscle viability. Complication of compartment syndrome are muscle necrosis, rhabdomyolysis, renal failure. So seeing complications of compartment syndrome, doing small fasciotomy, I think it's not harmful. So again, so amputation is like complication, but sometimes it's treatment also. So it's always life over limb. So in all three, Rutherford 3 ischemia, straight away go ahead with amputation. Doing revascularization is like invitation for reperfusion injury and means not managing case successfully. So take home message is we need ALI awareness for the better diagnosis. Every minute's count. So we need to fast track all these cases. Need a hybrid vascular surgeon to give complete solution. Thank you.
Thank you, Vineet. Any questions? I think what is summed up is that is what we all want to put the message across is that limb ischemia, you need to understand the complex pathophysiology before you choose the correct modality. And who better than a vascular surgeon to decide that? Those who are trained in not only the medical management, the open as well as the endo, they're the best people probably to deliver successful results in managing limb ischemias. Thank you, Dr. Vineet. think we quickly move on to the last session before the lunch. And this is another interesting session on acute mesenteric ischemia, something which all of us see all the time. And in the context setting, I would ask Dr. 𝐯𝐚𝐬𝐿 Singh. She'll present a brief case about a classical mesenteric ischemia and how it was successfully treated. Following that, Dr. Anirudh will talk on acute mesenteric ischemia and how it is diagnosed and managed.
Good afternoon, everyone. My name is Dr. 𝐯𝐚𝐬𝐿 Singh, and I'm a third-year general surgery resident. I will be presenting a case on acute mesenteric ischemia and walk through the history, examination, and investigation, and that would be followed by a comprehensive management by Dr. Anirudh. The history goes like this. It's a 60-year-old lady who presented to emergency department with chief complaints of sudden onset intermittent central abdominal pain since the past 4 to 5 hours. She was perspirating and was nauseous along with it, but there was no history of fever, constipation, or vomiting. She said she tried to take certain analgesics, but that did not relieve the pain. The pain was dull and cramping in nature. Her past medical records showed that she had atrial fibrillation, diabetes, and hypertension. However, she was not compliant with her medications. Now, on examination, on general examination, the main points were that she was dehydrated, which was evident by her dry skin, sunken eyes, dry mouth, and her pulse. She was tachycardic with a pulse of 108 and irregular pulse, which was in line with her atrial fibrillation. Apart from that, she was vitally stable. On abdominal examination, the abdomen was soft, but the mid-abdomen was very tender. However, there was no guarding and no rigidity. Now, retrospectively, post the diagnosis of acute mesenteric ischemia, it can be said that she was in the early stage of the disease, right here, as we know that the progression of this disease causes systemic and abdominal signs to worsen. However, in the early stages, the abdominal signs are much more prominent than the systemic signs. Now, by this point, contrasting the history to the examination, it could be said that the pain was out of proportion to the signs or the degree of abdominal tenderness, so much so that the signs were only the tip of the iceberg. Scientifically, we narrow down our diagnosis from symptoms to signs, and in such cases, latter is not that profound, which leads to a delayed diagnosis. I mean, so what if the diagnosis is delayed? That is the greatest challenge to reducing the morbidity and mortality. And studies have been done which shows that the survival decreases approximately 50 to 30% when diagnosis of SMA embolism is made 24 hours after the onset of symptoms. Now, to quickly go through the investigations, her stools were positive for occult blood owing to the affection of mucosa first. Her 2D echo showed LV clot and an ejection fraction of 30% in line with her atrial fibrillation and in line with her sudden symptoms, helping us determine the root cause. The ABG showed no lactic acidosis, confirming the relatively early stage of the disease. The CT angio showed as an SMA thrombosis, SMA being the most common because of its oblique origin from the visceral aortic segment. There was no pneumatosis intestinalis or gas under the diaphragm. Now, completing the investigation, I'll just touch on the management, which was resuscitation and critical care. The patient was given isotonic crystalloids, invasive monitoring by arterial line, invasive central line, and Foley's catheterization. Broad spectrum antibiotics were given, as well as IV heparin was started. Now, coming to the fact that it was early, and early in endovascular revascularization was done, the access being femoral. Then you cross the lesion, you go ahead and do the aspiration embolectomy, and then a balloon-mounted stent was put in place. Thank you. Now I'll ask Dr. Anirudh to please help us with the management. Thank you.
It's basically a paradox, acute mesenteric ischemia before lunch. So I'll be discussing with you about acute mesenteric ischemia Diagnosis and Management. I'm Dr. Aniruddha Bhuyan. I'm a vascular surgeon in Mumbai. Now, this is what we don't want. We want to make sure that this does not happen. If a patient of acute mesenteric ischemia comes, don't wait till the bowel becomes gangrenous. What is mesenteric ischemia? Basically, there are three things: arterial occlusion, venous occlusion, or NOMI, which is non-occlusive arterial vasospasm. It can be acute, which is absolutely new clots. It can be chronic, where the patient has been suffering for a long period of time. And if it progresses to bowel necrosis, infarction, perforation, it actually leads to death. The main thing what we need to know is there are two blood vessels in the gut. The primary gut is supplied by the SMA, and the inferior mesenteric artery supplies the latter part. And these patients, as Dr. Sumanshi said, presents with abdominal pain. It can be colicky in nature previously, or a sudden onset pain which is completely out of proportion, which is mostly an acute mesenteric ischemia. There is normally abdominal distension. There can be tachycardia, hypotension, which has already been covered. Now, what is acute arterial ischemia? It is primarily, as you can see here, there is a blockage in the artery. There is no supply to the gut. Now, initially, there was embolectomy advised a lot of years back, and the mortality is very high. Patients normally die because of SMA thrombosis. And vasodilatase and anticoagulation was started long back, but it hasn't been improved since a long time. And interventional options earlier was used for non-occlusive mesenteric ischemia. Is it really so? Let us go through. Incidence-wise, females are more prevalent. They are almost 1 to 1,000 admissions. And if you see in embolic episodes, in AF, in myocardial infarction, there is quite a few cases. In COVID, we saw a lot of cases of acute mesenteric ischemia. And the most common presentation is hemodynamic insult, and that is normally the later stage of the disease. If you can classify, it's arterial embolism, which is 40 to 50%. It's either cardiac or embolic. It can be arterial thrombosis, which is about 25 to 30%. And there is normally a chronic also component associated with this. It can be non-occlusive mesenteric ischemia, where it is mesenteric vasospasm, and that's about 20% of the cases. There is primarily a narrowing of the branch. You can get a string of sausages sign, and there is impairment of filling in the mesenteric vascular arcade. Now, the diagnostic evaluation should be quick, because the diagnosis is basically you're saving the life of the patient as well, if you diagnose early. The CTA is the gold standard. And until transmural involvement of the gut occurs, there are normally no symptoms. And thus, what you should do in such patients is send for all the parameters, amylase, LDH, AST, CRP. You should also always, as the gentleman behind had said, check the D-dimer levels, because D-dimer tells that somewhere in the body there is a clot forming or a clot breaking down. And if the ileum is involved, if you have specific tests, you can do an ileal bile acid assay, which actually is a binding protein. The other thing, a basic investigation is an abdominal X-ray. You can get bowel wall edema, thumb printing, or pneumatosis. You can do a duplex ultrasound, which can actually see the gut getting the supply, whether it is less or it is more. And normally in acute mesenteric ischemia, I mean to say, the bowel gas is a lot. So mostly duplex ultrasound is not the primary choice. It's a CT. In the X-ray, you can see a pneumoperitoneum. If it's quite a late presentation, you can get pneumatosis, where there can be bowel wall infarction and necrosis in that area. So in such cases, you should not wait. Go, open the gangrene, cut it out, restore the function of the gut. Normally, MRIs in such cases are not preferred because of the poor spatial resolution and because of the fact that you can't go into the smaller vessels. You can't see the smaller vessels at all because the MRI contrast does not go too much. And if you have a diagnostic laparotomy, you can get the serosal color. But that is one of the most primitive ways of checking. There is also fluorescent angiography, which is more sensitive, where you can get a UV light. You can do it laparoscopically as well. Now, the treatment is stabilize the patient, treat the anomie, get a primary treatment of medical, extensive critical care support, and if there is peritonitis, operate the patient. And you can also give intra-arterial vasodilators like papaverine, which actually was started with Miyonoshi et al., where NOMI was treated with IV and or IA prostaglandins, the dose as given. The surgical treatment, yes, we are vascular surgeons. We treat open and endo both. So let's start with the open surgeries first. You open the gut, you make sure you open the superior mesenteric artery, you give an embolectomy incision, and you remove the clot if you can. These are some of the bullet-shaped clots which we remove from the gut. You can also do a bypass if, for example, there is a chronic sort of a presentation. This is basically one branch to another branch bypass with a reverse saphenous vein. This is with a femoral vein. You can do a 𝐼𝐤𝐵 to SMA bypass, either with a vein or a graft. So basically, which graft? Normally, we use a caliber of about 6 to 8 millimeter Dacron or ring PTFE. You can also use GSV or femoral vein, which are good conduits. The most importantly is assessment of bowel viability. It has to be quick. So the bowel is viable for about 20 to 30 minutes of reperfusion time, which is permitted. Normally, we look at the anti-mesenteric border of the bowel. And if there are signals in the anti-mesenteric border, you know that the bowel will survive. If there is no, then there is always a 50-50 chance that the bowel may not. There is fluorescent as well. You can do a laser Doppler flow meter. And the most important, as surgeons, clinical judgment is very important. The endovascular treatment, it can be either hybrid, where we can open the bowel, we can see how the flow is, we can go in, you can do a retrograde artery thrombolysis or stenting. A note is about visceral and dynamic, static and dynamic dissections as well. One needs to know that a dynamic dissection does not have any clot. A static dissection normally has a clot. It is blocking the way. There is a difference between a true and a false lumen. The most importantly is don't get afraid of looking again. A second look surgery is always important, sometimes because you can sort of miss the gangrene, and you normally do this 12 to 48 hours later. It prevents an irreversible systemic sepsis if the bowel necrosis worsens. Very important, again, as I've said, to use intraoperative vasodilators. So basically now you know about what needs to be done. How do you proceed with such patients? This is just an example of a case. This patient comes to you, you see a complete thrombosis of the superior mesenteric artery. You see no flow going down. And if in the lateral view, you see that there is a clot. You see a little bit of streak of flow going down. What will you do? Will you wait? Will you give anticoagulation? Or you go in and try to treat as much as possible? Now, this is what we want. This is an arterial flow. You see a complete cutoff over here. You see blood flow going into the gut. This is what normally it should be. And you want it to become like this. These are multiple cases which we do. This is an arterial clot. You go in, you thrombolyze, you get the flow into the gut. Similarly, in this case as well, let me show you a case. We did quite a few cases in COVID where we thrombolyzed the patient. We made sure that the gut was open, and we prevented an operative laparotomy and gangrene with the bowel wall resection, which was given in Times of India in 2021. Now, what we did was that this patient, say, presents with an intestinal gangrene, meaning going to be a gangrene, sort of, in acute abdomen. You find in the CT there is a clot here. You find that it is not NOMI, because you can see the clot here as well. It is not a vasospasm. So what we do is we go into the arcade. You see that, oh, the SMA main trunk is quite thinned out. There is thrombus. There are side branches. So we try to negotiate first into the SMA main lumen. Now, after we negotiate into the SMA main lumen, once a wire goes down, we place a thrombolysis catheter into the SMA main trunk. Now, this gives actylase, which is basically a thrombolytic agent. And after that, you find, oh, the SMA has opened up. That's great. But what about these branches? Okay, so try to open as much as possible. So we inject thrombolytics again. And with this, we start getting a complete flow. Okay, so this is acute. Now, what about the this is what we get, a complete flow. What about the chronic guys? Now, this is a patient who is thrombolized, is acute on chronic. You see a lesion over here in the center. We do a plasty, we do a stenting, and we get the blood flow going into the gut. So this is all about arterial. Next is venous. I'll just touch. So this is an arterial occlusion. This is a venous. You see arterial is more spotted because there is a cutoff of blood supply, there is gangrene. Whereas venous, on the other hand, is more of congestion, where the blood is not able to really drain out. So it's very important to know or have a difference between an arterial and a venous mesenteric ischemia. And the epidemiology in females for arterial was more. In venous, it is more or less equal. And these patients, 16% of them have both acute mesenteric arterial ischemia as well as venous. The most common causes of such is postplanectomy, IBD, acute pancreatitis, cirrhosis, obesity. And one should always note about the thrombophilic tendencies in such patients. You do a genetic factor, factor V latent mutation, a prothrombin gene mutation. You can also do myeloproliferative factors and also the acquired factors, which are protein C, protein S, can always be done later once the thrombotic event has gone away. And the treatment normally is you do a CT, you do an imaging, you do also a portal venous phase, because the portal vein, IMV, they are quite main veins which also contribute with the SMV for the thrombosis. And once you get thrombus in the portal vein or there's congestion, normally it can end up with tissue edema and infarction. So in such cases as well, the treatment could be thrombolysis. As clinical, meaning clinically I can tell you for my patients, I normally go into artery because the main problem is in the vascular bed. So I go in the artery, I give thrombolytics, although the clot is in the vein. So that goes into the vascular bed, it clears off the congestion and sort of make channels in the vein rather than giving thrombolysis directly into the vein, which does not open the vascular bed at the end of the day. So aspiration is also a good option where you can actually locally inject into the vein and aspirate the clot out. And if surgical, then definitely you need to cut off the gangrenous segment. And because if there is thrombosis, there is infarction, you need to cut it off. So my main aim of this talk was that if there is mesenteric ischemia, there is bowel infarction, and there is necrosis and perforation. So timely intervention is key. So from a person who is diagnosing it first to the emergency department, to the time on the OT table or the cath lab table, it is very important to get the patient on time. Thank you very much.
If there are questions from any audience regarding ischemia, I think just before lunchtime, I think everyone is. If there are no questions, I think what we do is we'll break for lunch. And I think after that, we'll have a venous session post-lunch. Yeah? Which venous cases we see much more than the arterial. So I think it'll make an interesting hearing. So what we'll do is we'll break for lunch now. I invite all of you for joining us for lunch.
PTS, that is post-thrombotic syndrome, the severity was less in thrombus removal strategies. The drawback of this meta-analysis were lack of uniform consensus on stenting, therefore less stenting were done. The current best practice were not used. The device used for the thrombectomy are no longer available in market now. And IVUS was not used to delineate the common iliac vein anatomy. So where does early thrombus removal stand nowadays? In both provoked and unprovoked DVT, if the bleeding risk is less and iliofemoral, there is iliofemoral acute DVT and symptomatic, the recommendation is class 2A. That is, you can offer patient the early thrombus removal strategy with good benefit. So conclusion, early thrombus removal that is less than 3 weeks should be considered in DVT patient with low bleeding risk with involvement of iliophaeum segment to prevent morbidity associated with post-thrombotic syndrome. Thank you.
Thank you, Dr. Ritesh. That was in a gist about deep vein thrombosis. I think you very nicely clarified that in most cases DVT would be treated with anticoagulants, but there is a subset of patients where interventions are certainly mandated, and the reason is that it not only causes an early relief of symptoms, but also reduces the long-term post-thrombotic syndrome risk. So we'll move on to the next part of the deep vein of the thrombosis, which is pulmonary embolism, something we all fear. And so I think we start with Dr. Gopal Goel will show us a typical pulmonary embolism case, and thereafter Dr. 𝐯𝐚𝐬𝐿 will talk about management options. Prevention of thrombosis, thromboprophylaxis. Ma'am, yeah. So ideally, what we do is what you're talking about is thromboprophylaxis, which is unfortunately so underscored in our society that most of us are, in the healthcare system are geared to treating rather than preventing. That's the flaw in our healthcare system, and so your question is very relevant. Thromboprophylaxis is mandatory. So if you have say for instance, in a lady who's taking a long flight, what we advise our patients is, there is a misnomer, it's called what is called an economy class syndrome. Now, it is not that it occurs only in economy class. Even business class or first class passengers are prone to deep vein thrombosis. So those who have long flights or long bus journeys, long car drives, long by definition is anything more than 4 hours. So if you have a flight more than 4 hours or a bus journey more than 4 hours or a car journey more than 4 hours, we tell our patients a couple of things to prevent thrombosis from occurring. One is to keep, if those of you who have traveled to the UK, you will find that when you travel by National Express, on the back seat of your thing, there is a leaflet telling you that you are on a long bus journey. To prevent deep vein thrombosis, keep moving your ankles up and down. Same thing we tell our patients, you are on a long flight, keep moving your ankles up and down. Every 2-3 hours, get up, take a walk down the aisle. Avoid alcohol during flights because alcohol is the most potent dehydrating agent. And when your blood becomes thicker and you're as such, when you have too much alcohol, you are already zonked. So your physical activity is down, you are dehydrated, and that is a good, kind of a source. If you're already in the high risk group, wherein you have had a thrombotic event in the past, what we tell our patients is to take a thromboprophylactic drug, either in the form of a rivaroxaban tablet or an LMWH 2 hours prior to the flight, and that virtually covers for the entire flight. So those are things which we need to tell, but unfortunately, as I said, our healthcare is more geared to treatment rather than prevention. So we don't actively tell our patients till they ask us. which is the problem. Overseas, it is part of the system. So, as I said, if you go in a long-term bus, long journey bus, such information is already there in the pamphlet in the front pocket of your front seat. So while you are just traveling, you pull it out and it tells you, you are at high risk of DVT, please do this. I think that's what, as primary care physicians, probably that is something we need to add to our armamentarium when we talk to our patients, they're going on a long flight, some small bits of advice on thromboprophylaxis. Well, the truth about TET stockings is now more or less out in the public domain. A lot used to be said about stockings, but slowly now the whole concept of stockings preventing deep vein thrombosis is going out. And from what information I have, in the near future, in the NICE guidelines, TET stockings is not going to be there. That is the truth about, for donkey's years, TET stockings used to be one part of the protocol for prevention of thrombosis, but more and more evidence is there now to suggest that merely wearing stockings is not really good enough. Post-op pumps, yeah, the pneumatic compression pumps are much more potent than merely wearing the stockings. So stockings is probably a little bit industry driven. And as I said, when I last met some of my colleagues from the UK, they said probably in the next NICE guidelines for thromboprophylaxis, these stockings for prevention is going to be out. Yeah, I think Dr. Gopal can present.
Good afternoon, everyone. I'm Dr. Gopal Goyal, second year general surgery resident from 𝐬𝐮𝐫 Hospital. I'll be starting my case presentation on pulmonary embolism. So my patient who presented was a 59-year-old male. He was a senior commander with a leading airline. So he came with his wife in accident and emergency 8 a.m. in the morning with complaints of chest tightness, and also he had a shortness of breath. Now the important history here was that he had a recent travel history, as sir just now said, of more than 4 hours as he returned from Paris, and he had a complaint of shortness of breath and tightness in chest. So his wife applied Vicks Vapor Up and the night somehow passed, but since his symptoms were not improving, so in the morning he came to accident and emergency. So when he presented to us, we checked his vitals and his pulse was 80 beats per minute. Blood pressure was around 110/80. His saturation was 90% on room air when we checked with SpO2 probe. His ECG was normal. We also did a bedside 2D echo where we saw RV dilatation. Also there was some septal deviation, but ejection fraction was 45%. And there was some labored breathing, but patient was overall okay. So after taking the history and examining him, we suspected that this might be a case of pulmonary embolism. So we sent some blood investigations such as D-dimer and cardiac enzymes, which included NT-proBNP and TROP-I. And we asked for an urgent CT pulmonary angiogram. So in CT scan, we saw a saddle embolus in the main pulmonary arteries. Also, there was an extension of the embolus into the segmental branches. Now, when we checked the labs, there was a raised D-dimer which was more than thousands, in the level of thousands, and both in proBNP and TROP-I were also raised. So we, after seeing the CT scan and blood levels, we found our case to be pulmonary embolism, and we planned for a catheter-directed procedure as patient was fairly stable. So rather than systemic therapy, we thought of catheter-directed procedure. And after consenting the patient, we shifted him to cath lab within 30 to 40 minutes. Now, this is this catheter-directed thrombolysis. So what we did was, the procedure was done under local anesthesia, but we kept an anesthetist standby. 10 ml of recombinant TPA was pulsed into each side, and we sucked out the thrombus after 10 minutes. Within 30 minutes, the patient improved, and the saturation was 96% even at room temperature, room air. And now the important finding one here is that we also did a leg scan of the patient, and although there was no symptoms when he presented in A&E for his legs, but there was only mild ankle edema. So we found out that he also had a popliteal deep vein thrombosis. So maybe that was the cause of the pulmonary embolism. And after stabilizing, the patient was discharged on day 5th with oral anticoagulants. So pulmonary embolism is a fatal disease and need to be monitored. Thank you. Now I'd like to call Dr. Vora for further.
Yeah, thank you, Doctor. I think this is a true story. Unfortunately, the airline where he used to work no longer flies, Jet Airways. This is a really scary situation, and you can very well imagine, a commander of a flying flight going to Paris, and he has a DVT, and he gets a pulmonary embolism on flight. Of course, I'm sure there are, other pilots also but it's a really scary situation, and it's a real life situation. I thought I should share this case with you, and I think Dr. Vora will talk more about how one manages such cases.
Thank you, Dr. Gopal, for a nice case. Good afternoon, everyone. I am Dr. 𝐯𝐚𝐬𝐿, Vascular and Endovascular surgeon, and I am going to brief you about the treatment modalities, newer treatment modalities in pulmonary embolism. Yes, rightly said that pulmonary embolism kills. Why are we concerned? Because 50% of the cases are asymptomatic, and proximal DVT has higher incidence of converting into pulmonary embolism. In high-risk group, there is almost 5% mortality rate. And Endo states rightly that thromboprophylaxis rates are very much lowest in India. So are we in denial? Yes, probably. So distal DVT is most common, and many a times they go undiagnosed. They are just treated as swelling. Approximately 15% of this patient extends to proximal segment. So even though pulmonary embolism is underdiagnosed, yet it's important cause of morbidity and mortality in patients worldwide. So in spite of increasing awareness in India, like we are doing today, so depending on which specialty treats it, the management will vary, which is a big challenge. So some background on pulmonary embolism. Acute pulmonary embolism stands third leading cause of death worldwide. US alone reports more than 1 lakh deaths annually. And why is this so? Probably the acute pulmonary embolism interferes in both gas exchange as well as circulation. But some good news is, with the advent of newer modalities and treatment, the prognosis is going better and better. So catheter-based options are turning out to be a crucial tool in management of acute pulmonary embolism. So somewhat acute pulmonary, once it's diagnosed, it's classified into a high risk and low risk patients as per if patient is having hypotension or not. So like Dr. Gopal explained that CTPA, echo, 2D echo, pro-BNP, D-dimer, TROPI, these are the tests which we do for diagnosing acute pulmonary embolism, of which CTPA is gold standard. So once the acute pulmonary embolism is diagnosed, the age-old treatment, the traditional treatment is to start with systemic thrombolysis. The ACCP guideline says injection atiplase 100 milligram is injected intravenous route over 2 hours. Overall, 90%, more than 90% of patients benefit with this treatment as shown on the echo findings as well as clinical findings. The greatest benefit is observed if the treatment starts within 48 hours. But it has many contraindications and as well as complications. Systemic thrombolysis are associated with almost 20% risk of major bleeding, which includes 2 to 5% bleed, intracranial bleed. So it's a problem. So what is the answer for it? So the answer is catheter-directed therapy, which shows low chances of major bleeding, more direct removal of the clot, and rapid restoration of the blood flow. You remember I told that it's a big challenge which specialty treats it first. So that calls for a need of multidisciplinary team, which was formed as a pulmonary embolism response team, where vascular and endovascular surgeon forms a crucial role. So once a patient of acute pulmonary embolism comes in A&E, they start with anticoagulation and classified as per this charge into high risk, intermediate risk, and low risk patients. High-risk patients are directly started with systemic thrombolysis unless it's contraindicated. Intermediate and low-risk patients are offered catheter-based treatment, which I'm going to talk in detail. Sorry. So this is the selection of intermediate risk patients. These are the therapies offered, and they are backed by key trials and outcomes. So the primary aim is to achieve the vascular reperfusion of the pulmonary system and thus reducing the overload on the right ventricles. So the first in this category is ultrasound-assisted catheter-directed thrombolysis, where 𝐬𝐮𝐫 is FDA approved, but unfortunately not available in India. It relies on the principle of directly drug delivering into the thrombolytic agents delivering into the thrombus using ultrasound energy, and which is backed by many trials where it has shown promising results in decreasing the RV to LV ratio. Right now, ongoing prospective registry is knocked out PE, which is enrolling more than 1,500 patients. As compared to that, the second option is standard catheter direct thrombolysis, where many types of catheter like Craig-McNamara, Unifuse, fountain catheter are available, which has multiple side holes in it, and they directly distribute the fibrinolytic agents into the thrombus. The main advantage is compared to ultrasound therapy is low cost, and when we compare ultrasound therapy with the standard catheter therapies, the outcomes are equally good. Third option is mechanical thrombectomy without any thrombolysis. The advantage is quicker removal of obstruction and without using any fibrinolytic agent. Penumbra indigo aspiration catheter is freely available in India, like Dr. Rohit has explained. But the disadvantages are it needs a large bore catheter, which calls for catheter puncture site complications, distal embolization of the clot into the normal parenchyma of the lungs, and aspiration is associated with significant blood loss, as well as it's difficult to aspirate large size thrombus. The fourth type is pharmacomechanical thrombectomy with thrombolysis. It works on the principle of macerating the clot, increasing the surface area, and directly delivering fibrinolytic agent even on the lower dose. Mostly evaluated in the DVT trials, like Dr. Ritesh explained. The 𝐬𝐮𝐫 is freely available, and it works on rheolytic thrombectomy device. So to summarize, catheter-based treatments are emerging as treatment of choice in all the intermediate risk pulmonary embolism patients, which forms a higher number of cases with low risk and potentially good result. So this is one of the cases which Dr. Gopal has already shown, and the results are very promising. Now coming to some controversies that whether to use IVC filter or not. The ACCP guidelines says recommends it against the use of IVC filter until unless there is a contraindication of anticoagulation use. So use of IVC filter is only recommended if in the setting of active bleeding. Routine use results in increased complications and a cost burden on the patient. ECMO in high-risk patients, I will not discuss. It's a big topic. Adjuvant pharmacotherapy, which we all know, we have discussed, like low molecular weight heparin is better than ultra-fractionate heparin because it's achievement of direct therapeutic anticoagulation effect. We use 1 milligram per kg body weight every 12 hourly until unless there is some renal dysfunction. If we are using ultra-fractionate heparin, then we have to maintain a target of 2.25 times of PTT. The newer oral anticoagulation is discussed in very detail. This is the chart shown by Dr. Tulpule. Why NOACs are useful? Because it's like single drug approach orally administered, limited drug interactions, and lack of monitoring requirements. So to summarize, the key to successful management of acute PE is early risk rectification and treatment. A multidisciplinary approach by PERT concept and model has demonstrated positive outcomes. Though systemic thrombolysis continues to be most commonly employed reperfusion technique in treating acute pulmonary embolism, but looking at all the complication and contraindications, catheter-based therapies have emerged to be an exciting and potentially viable option. Thank you.
Thank you, Dr. Smith. So to sum up what he said, pulmonary embolism, 3 groups: high risk group, unstable patient, no discussion, systemic thrombolysis; low risk group, just medication. There is an intermediate risk group where you need to hospitalize, monitor, and how you monitor with the cardiac enzymes and repeated 2D echoes. If they are worsening, there is a scope for putting in a catheter and lysing the clot, dissolving the clot. The advantage of that treatment is that you require a lower dose of antithrombotic drug like Actelyze. So you use less drug, so the less complication, bleeding risk is much less. So that is in a gist about what Dr. Vora said. Now we've talked a lot about filters, a lot has been mentioned. So Dr. Srikanth again from Pune will tell you in a gist over the next 10 minutes what is all about these IVC filters, when are they indicated, when are they not indicated, where they are misused. So please go ahead.
Good afternoon, everyone. Myself, Dr. Srikanth, and I'm a vascular surgeon practicing in Pune. So we'll be discussing very short topic, IVC filter. So as Dr. Smith said, DVT does not kill, but PE does. So how basically we can prevent this DVT using this IVC filter? So we know different types of filter. This is T filter, water filter, and most loving, everybody knows the beauty filter. So this is all to make our life easy, beautiful, but this is the filter that will save our life. So what basically this IVC filter is, so this is a medical device that actually causes the vena cava interruption, and by preventing that blood clots to reach from your legs or upper limbs to reach to the heart and lung. So as we know that PE is the life-threatening, and this is the most preventable cause of death, that we can prevent it by judicial use of this IVC filter and the anticoagulation. We know that anticoagulation is the main treatment. So does all patient with DVT require filter placement? No. So what are the basically genuine indications, absolute indications? So documented venous thromboembolism with the contraindication to the anticoagulation. When there is a contraindication to the use of anticoagulation, we can use the filter. When there is a complications due to anticoagulation, or we're not able to achieve therapeutic level because of anticoagulation. So failure of anticoagulation, complication, not able to achieve the level, in that situation to prevent the pulmonary embolism, we can use the IVC filter. Then there is related expanded indications in which that many of the vascular surgeons before me that have discussed that while doing some procedure, when there is a free floating thrombus, or the patient with the high risk surgeries or going for surgeries, and we can't give the anticoagulation, in that situation it is also indicated to use the IVC filter. There are 4 types mainly, basically permanent filter. In old days everybody used to use the permanent filters. They are basically designed, they have the strong fixation points. So in your IVC, so they were like basically in thought that throughout the life they will give protection from PE. Why not? What is the issue? That we'll discuss later. Then comes the optional or retrieval filters. Like I said, Dr. Ritesh shown like during the procedure we used to put the filter, and after the procedure we used to remove. So these are basically type of filters. They have the design in such a way that we can remove it in later course of the treatment. The temporary filters, they are basically they don't have any fixation, means they are suspended in IVC, and with the help of catheter or wire they are, and somewhere it comes near to your subcutaneous plane or buried, or they are just out of sheath for some temporary purpose. Convertible, basically these are the permanent filters. They change some design, So later on, we can remove that permanent part and the rest of the metal just stays there, but it can be converted into the non-filtration part. So basically what we use nowadays is the optional or retrieval filter. Why, that I will explain in the latter slides. So based on designs also, there are different types of filters. We have conical, double fixation level with the helps of some uses some barbs or hooks for the fixation. So based on designs, there are multiple types of filters available in market. So how we basically place it? So there are basically two types of, two routes of putting the IVC filter. One is the jugular way and one is the femoral way. So jugular, this is the, how we can place it, that basically venographically, with use of venogram, and with that guidance we put the filter, or transabdominal, use of transabdominal sonography, duplex ultrasound. That also can be placed in the patient where some CKD patients, the patient CKD but not on dialysis, or some risk of contrast allergy. In that situation, we can use the transabdominal duplex ultrasound guided placement, or even we can put intravascular ultrasound guided with the help of IVUS. So most commonly, what we prefer is that the venographically guided filter placement. So this is the way, the approach, I can say. This is the approach. So this one is the basically that filter is placed from the IJV route. So we take the access in the internal jugular vein. We with the wire and catheter, we park the wire in the under the catheter in the IVC, and deep down into the iliac vein, we take the venogram. We check whether there is thrombus in infrarenal part of IVC, and there we place the filter. Basically, these filters are placed in infrarenal IVC level, because your filtration, the hook at the topmost part should come at the renal level, so that there should not be any stasis of flow at the conical part. So the other is the femoral route, which video has been well shown by the Dr. Ritesh. During the procedures, we can say through the same axis we can put the these filters. What things to be considered during the filter placement? So which are the most important thing is the anatomical consideration, that is the position of renal veins. The variations, there can be multiple renal veins, there can be IVC transposition, IVC duplication, agenesis. So even filter looks like very simple thing, it is not easy. If you miss any of these things, and you can see the surprise on the tables. If you don't see your CT venography properly, or if you don't assess the patient. So if there is some patients having chronically occluded IGVs, iliac veins, then there is a difficulty in placing the filter. So axis consideration is also the important part. The other is the technical part, that is suprarenal placement. Like I said, we always take a venogram while putting the filter. If there is any thrombus in infrarenal IVC, so if you put the your filter in thrombus itself, it's not going to help in any way. So other thing is the pregnancy, that we consider that we have to put the filter in little bit higher position, because the ultimately uterus, everything that can compress infrarenal part. The IVC size is also important, because filters, they are recommended for particular size. If it is more than 25, 23, then again it's not going to hold and it can land up into the right atrium. So as we place it, we have to remove it also. Like why we remove that, one of the slide, Dr. This one, Simit Ora sir discussed why we remove, what are the issues that we'll discuss later on. First we'll see how we remove it. So basically, like I said, these are temporary, there are retrieval filters. We have the hook. So we basically grab that hook with the use of snare, and then everything system we pull into the catheter itself. And followed by we check the, take the shoots, the venogram, to see that there is any injury to the IVC. So why, like I said, why we choose the optional or retrieval filter is these are the short-term complications, but the long-term complications are important. If you keep the filter in IVC in the long period,
we can get such a complication, filter migration, tilting, strut fracture, IVC perforations, IVC thrombosis. So the last important thing is that IVC thrombosis. So basically what IVC thrombosis, again it can lead to the DVT. So these are the pictures basically shown that there are complications in the long-term positioning of the filter in IVC. So there are evidence, PREPIC trial that has shown that in the long term, the filter itself don't give the protection against the pulmonary embolism, but in fact it can cause the DVT. So there is increase in DVT incidences, secondary DVT incidences, and there is no difference in the mortality. So that's why the filters, what we prefer to choose, they are retrieval optional filters. Initially the few years back, there were a lot of mainly the cardiologists, they used to put the filters and they used to leave it there. But nowadays there is no use of such a long-term use of filter because they don't give any protection. In fact, it can cause the complications. So what we come across that because of these filters, we are getting a lot of cases of secondary DVT, and that's how we recanalize this. Sometimes we have to go to extent that we have to use the bronchoscopy forceps to remove that filter. Sometimes we balloon it, we stent it, so to get that flow normal from your iliac vein to the IVC. So these are the basically to deal with the complication of IVC filters. So DVT-like treatment, the most important is anticoagulation. If no bleeding risk, everybody has discussed that now that we do catheter-directed thrombolysis, mechanical thrombectomy. But if there is bleeding tendency, what we put is the IVC filter. So IVC filter are used mostly in a bleeding tendency risk where we cannot give the anticoagulation, but it can be combined with the mechanical thrombectomy. So it's very nice, good tool, but if we use wisely, otherwise it can cause the catastrophic effect. That's all from my side.
So if there are no questions, I think, thank you, Dr. Srikanth. We'll move. Yeah.
Basically, if patient had initial history of any bleeding, intracranial bleeding, or if patient had some recent history of GI bleeding, where we cannot give the anticoagulation, in that situation, we prefer to put the filter. Yes, in pregnant. No, with that time we sometimes use the protection devices also, or we can, like I said, we can put the 𝐼𝐲 guided, we can put the transabdominal USG guided also, we can put the filter. Yes, we can use the 𝐼𝐲 if these settings permit.
Intravascular ultrasound. You can use it under, even, people.
No.
In pregnancy, you can use, even people do it under ultrasound guidance as a bedside procedure. Yeah.
Oh, it is very close to right atrium, so.
I think in this session, we're not actually covering butt cherry. It's a totally different, I think, topic. So I think we'll move on to the next speaker, something we all want to know. How do you work up somebody has a DVT or a pulmonary embolism, thrombotic state? What are the kind of investigations you need to do in the lab? Lot of ambiguity, and I thought it's best that we have very senior faculty, Dr. 𝐧𝐸, please. And he will be telling us about the hematological workup in cases of thrombosis.
Good afternoon, everybody. While we are setting up the presentation, I
I would first like to thank Dr. Shekhar for this opportunity, as well as for the opportunity to listen to some very fascinating presentations which are life-saving, as we all saw. And so thank you all for your presence here today. I do feel a little like an odd person out in the midst of vascular surgeons, but I also realize that there is something common between a hematologist, lab hematologist, and a vascular surgeon, and that's the disease that we handle, which is thrombosis or thrombophilic states. Now, Dr. Shekhar wanted me to share with you what is the current trend or current approach for testing of patients who present with thrombophilia or a case of suspected thrombophilia. Now, why it is important for us to go through this current status is that, as happens in many medical discoveries, there is always a honeymoon phase wherein there is over-enthusiastic utilization of a technology or a procedure or approach, medical approach, till such time that one realizes the pros and cons of these approaches or these devices or investigations, and then there is a stability in the approach itself. So we have passed through this phase in thrombophilia testing. So I'm going to restrict myself to thrombophilia testing and the related issues. So we have gone through this stage, and we have seen how the trend has changed from over-investigation of patients where you suspect thrombophilia to today, wherein we do this investigation in a very restricted or in a conservative manner. And the reasons for that we will look at. Before that, for the postgraduates and maybe the younger colleagues of ours, I thought we'll just quickly go through the basics of thrombophilia so that we understand what we are talking about. So the word thrombophilia, everybody knows, means that there is affinity for thrombosis. And it usually indicates venous thrombosis. The terminology was used to describe venous thrombosis, although loosely some people can use it for arterial thrombosis also. But arterial thrombosis is a different ball game compared to the venous thrombosis in terms of the etiopathogenesis. And therefore, they are separately handled. And as we all saw, thrombophilia can be, of course, acquired or inherited. And again, some experts in this field use the term to describe only inherited tendency to thrombus formation. So there are these, confusions still existing, but as far as the majority goes, thrombophilia is venous thrombosis, increased tendency to venous thrombosis, and usually inherited. We don't talk so much about the acquired in the context of thrombophilia. And of course, the manifestations are listed here, such as deep vein thrombosis with or without embolism, thrombosis at unusual sites, cerebral and splanchnic vein thrombosis, purpura fulminans, which is a very unique presentation in protein S and sometimes protein C deficiency, and obstetric complications as seen in Epler syndrome. So these are the manifestations of patients who have thrombophilia. Or these manifestations point towards the presence of thrombophilia in patients where they are seen. Oh, you must be wondering, and this is something which we are taught in the undergraduate, at the undergraduate level, is why is blood in a fluid state? And if we understand that, we'll understand why it develops the tendency to thrombose or become, in a gelatinous stage as thrombosis. And that is because there is a predominant, antithrombotic or fibrinolytic mechanism in operation all the time in our body, in vivo. And that consists of two components. One we call as natural anticoagulants or inhibitors, of which antithrombin, protein C, protein S are members. And then the fibrinolytic pathway. The natural inhibitors or natural anticoagulants deactivate the activated clotting factors in the body, which are getting generated all the time as a part of homeostasis. While the fibrinolytic pathway, which is the other component, which causes or leads to the blood being in fluid state, is because there lies the fibrin strands that are being continuously synthesized in vivo as a result of the continuous activation of the clotting factors. So without getting into too much of details, we have to understand these two. And when this balance, which is today in all of us in favor of the fibrinolytic or the anticoagulant component is less, or there is increased forces of, or there are increased forces of thrombotic tendency, which we call as procoagulant forces, you get a situation where there is increased tendency for the blood to clot. So this is in simple how it happens, and you will understand then, once you understand this basic mechanism, what happens when we have deficiency of one or the other clotting factors. And as I mentioned that, the manifestations of thrombophilia or conditions which point towards the presence of thrombophilia are a few. In the earlier slide, I mentioned that. This is also listed here as the features which could suggest that the patient has a tendency to venous thrombosis. And that of course, is like early age of onset of venous thrombosis, unprovoked, or thrombosis happening as a result of minor provocation. Say, for example, just now there was a question about venous thrombosis developing during flights, and that is not necessarily normal. We all fly, we don't develop venous thrombosis. Some people will develop. So that may be a tendency, or that may be a situation where a person needs to be also investigated with respect to the cause of increased tendency for venous thrombosis, because that's not a major or provocative factor giving rise to thrombosis in a normal person. So that way you have to think of these various conditions which lead to suspicion of venous thrombosis or thrombophilia. And very importantly, we must realize that the manifestation of venous thrombosis is the outcome of interplay of multiple factors. It is never, or usually not, that a person inherits an antithrombin deficiency and he will always manifest as a case of DVT. It is not necessary. He will manifest as a case of DVT if there is another factor, one or more factors, which add to this prothrombotic state or thrombophilic state. So this is for us to please remember this. And therefore, the preventive measures or the need to test will be determined by the circumstances in which we are dealing with a given case. I have just listed here the various causes of hypercoagulable state or thrombophilia. And here, of course, acquired is listed. Of these, of the acquired, Apla syndrome is very notorious for causing both venous and arterial thrombosis. And in the morning I was asking when one case was being presented where there was a preceding venous thrombosis followed by arterial thrombosis, was this a case of Apla syndrome? Because that is a typical, what should I say, manifestation of Apla syndrome in terms of having both types of venous thrombosis, or both types of thrombosis, I'm sorry. So this is one important cause of acquired, and there are plenty which are listed there below. And then of the inherited, antithrombin deficiency is the most notorious in terms of the risk of causing DVT, as well as the incidence of DVT, in incidence in cases of DVT. So that is something which therefore I have highlighted in red. And I want also you to realize that prothrombin gene mutation, which comes as a part of a panel in many of the thrombophilia checkup panels, is not seen in Indians. And therefore, please do not ask for that test. There could be some anecdotal, questionable cases reported here, there, but we don't come across that. And therefore, very important not to ask for this investigation in patients of venous thrombosis. It will save the patient the money and the time, energy, and all that stuff. And in the other group, which is the third group, where you have mixed or unknown causes, one cause which was factor 8 levels, high levels of factor 8 were shown in some studies to cause DVT as well as arterial thrombosis. But later on, through scientific studies, it was proven that factor 8 elevation in blood does not necessarily lead to increased tendency to venous thrombosis. So please do not ask for factor 8 if it is part of the panel. And I'll get into that a little later. I just thought I'll bring this out in the context of the various causes of thrombophilia. Two slides that I'm going to show, again, are for mainly my younger graduates here, or maybe even useful for all of you, is the mechanism by which the factor 5 Leiden gene mutation works, or by which protein C, protein S deficiency also works, and gives rise to increased tendency to venous thrombosis. As you can see here, endothelium, when it is injured, endothelium is a very active, dynamic cell. And when there is even the slightest injury, there is increased expression of what we call as thrombomodulin. It is a protein which is very sticky protein that tends to bind thrombin. So thrombomodulin and thrombin complex that occurs when there is, which is happening all the time, gets inactivated or acted upon by protein C in the presence of protein S to give rise to activated protein C, which is required for inactivating activated factor 5 and factor 8. And factor 5 and factor 8 are very important procoagulants that are being generated in the body all the time. And if uninhibited, they can drive the thrombotic process, or the the coagulation cascade towards increased tendency to thrombin formation and fibrinogen formation and increased tendency to thrombosis. So this is in the absence of protein C and protein S, you get decreased production of activated protein C, and therefore decreased inactivation of factor 5A and factor 8A. And factor 5 Leiden is a mutated factor 5A. And as a result of that mutation, which happens at the site where the activated protein C acts to cleave the factor 5 to make it inactive, that doesn't happen when there is a mutation at that site. And factor 5 Leiden is such a mutated protein. And therefore, it goes uninhibited and keeps acting and cause increased tendency to fibrin formation and thrombosis. So this is one. And the other pathway which is very important for us to understand is the sites of action of antithrombin. And there are multiple sites at which it acts, and therefore the deficiency of antithrombin will lead to increased tendency to venous thrombosis. I did mention that of the various thrombotic or thrombophilic factors, antithrombin is very notorious, and therefore we must investigate patients of DVT for antithrombin deficiency. And in order of frequency, as you can see here, the others are also important, although the incidence is not that high. And of the acquired factors, lupus anticoagulant is a very important factor to keep in mind. And this slide I think I'll skip because it just shows you the various types of antithrombin potency and proteinase deficiencies, basically to say that why do we do, if you have to do one test for antithrombin, one test for potency and one test for proteinase, it's always important to do the functional assay and not the antigenic assay, because you will see there will be all kinds of options given to you to choose from. And functional assay is important because that's ultimately that is what matters. How functional is it? So in case of quantitative deficiency of these proteins, you will have decreased function in terms of the activity. And if there is a mutated protein, which is the defective protein, there also there will be decrease in function, although the antigenic level will be normal. So, but when you do functional assay, you capture both. And therefore it is, if you have to do one test for each of these, you please do a functional assay and not do the, quantitative assay. And for proteinase, it's a bit unique because it also has a free floating or free portion of the protein circulating in blood, which is the active moiety. And therefore, it is important for assessing free proteinase and not the total proteinase when you have an option to choose from. So these are the points to remember. Now coming to the goals of thrombophilia testing. Why do we want to do thrombophilia testing? Because there is a lot of debate as to how justified is it to prescribe thrombophilia tests, which are, many of them are expensive in a given case. Now, obviously we need to decide why we want to do the testing. And these are the various reasons why one would like to do these tests. The number one would be to take a decision regarding future VT prophylaxis. So once you have treated a patient with DVT does not require, one doesn't require to know the cause of DVT to start the treatment. It's a very important point for us to remember. And in the initial phase of availability of these tests, our clinical colleagues would ask for these tests left, right, center. And even patients would pressurize the labs, or doctors would pressurize the labs to release the reports early. And you can imagine these tests are not done very often, and it is economically viable only if it is done in batches. So there is this tussle going on. And, but if you see, you do not need to know the cause of DVT to start the treatment. The treatment remains the same irrespective of the cause of DVT. Why you need to know the cause? You would like to know the cause when you have to go beyond 3 to 6 months, that is mandatory management with anticoagulation. Beyond that you want to know. So there it is going to be helpful. And therefore you have to keep that in mind to guide testing of family members, especially in regard to risks associated with oral contraceptives and pregnant females of family member who are family members of known cases of DVT. So in very specific, and this point has to be emphasized very strongly, that is the relatives of, or direct first level relatives of patients who have proven etiological factor of deep vein thrombosis, where it has been proven by investigations. There you need to do an investigation, because that person has a high risk of inheriting the same defect and therefore landing up in problem when the additional risk factors which I was talking about, like oral contraceptive, pregnancy, particularly in the context of women, comes into play. So this is very important for us to remember. To determine the cause, especially severe VT, fatal VT, and in family members of VT in an unusual location. So again, patients who are known to have severe DVT or fatal DVT or unusual site DVTs, where there is a cause of these manifestations, you would like to know that in the family members who are getting into a higher risk because of the various physiological and other lifestyle related issues, and to determine the duration of anticoagulation. Now, this is something which is again a highly clinical decision, and therefore, just because a person has antithrombin deficiency and not proteinase deficiency, and therefore that person would require more or longer anticoagulation, that doesn't hold true. So this is something which is clinical. Again, to cut the long story short, we should not test the patient when at the time of active thrombosis. The reason for that is obvious, because you can imagine when there is an active thrombosis going on, or immediately thereafter, the process of thrombosis is consuming these clotting factors, that is, factor 8, factor 9, all these clotting factors, as well as the natural inhibitors, which are that you want to test, like protein C, proteinase, antithrombin, because they are also acting to neutralize these activated factors, so they get consumed. So when you do an assay at that time, you are bound to get erroneously low values and misdiagnosed cases as having these deficiencies when actually the patient doesn't have that. And therefore, on one side, the management of the patient doesn't change, whatever may be the cause. On the other side, you are going to get, abnormally low values when you do the investigations during the time of active thrombosis. There are two very solid reasons why you should not be doing these investigations at that time. And of course, you would not do the testing when the patient is receiving anticoagulation. So once you have put the patient on anticoagulation, although there are some tests which will not be affected by anticoagulation, and that I will talk about a little later. But again, what is the urgency? And that's a clinical decision, whether you would like to investigate a patient on anticoagulation for the thrombophilic factors. Is something which is a conscious decision, and there has to be solid reasons for doing that. And you would not investigate patients when you have very clearly proven provoking factors, like major surgery, long immobilization. So when you have this kind of a scenario, even normal people can get, and in fact, we did a study in lower limb arthroplasty patients when I was working at Hinduja Hospital, where we showed, and we all know that patients of lower limb arthroplasty, about 20%, 25% of them have a tendency to develop venous thrombosis post-op. And that happens even though they are on prophylactic heparin. So we wanted to know whether the people who are developing venous thrombosis on prophylactic heparin, undergoing the lower limb arthroplasty, do they have a reason or some thrombophilic state versus those who don't develop? And we didn't see any difference, meaning thereby these are local causes. And therefore, why do you investigate? So you need not investigate even those cases. Am I running short of time? So there have been a lot of controversies, discussions, debates, and you can imagine on one side these expensive tests are to be done. We are not very clear as to what is the role of these investigations, how much are they going to impact the management decision. All that stuff has been happening over these last 2 decades, following this honeymoon phase that I was talking about, of these tests being available. Various societies, and this is it's a picture of the recommendation criteria based on which the recommendations were made by the American Society of Hematology for testing patients for thrombophilia. And there were 23 such recommendations. So you can't go through all the 23, and most of them say don't test. So what I have done, I've just brought this to impress upon you that although I work in lab and the general tendency would be to think that since you represent the lab, you would advise or advocate testing. But this is one case we will not advocate testing. And there are solid reasons for that. And this is a point to be kept in mind. And so out of these 23, only 5 areas or 5 broad groups that have been identified, which I just now referred to also, wherein you need to do testing. And what are these? Patients with VTE associated with non-surgical, major, transient, or hormonal risk factors. Now, you have to understand what it means. Major, non-surgical, transient risk factors, which are not known to cause thrombosis. And if they are causing thrombosis in a patient, and people who are getting thrombosis on receiving these various hormonal therapies, particularly women obviously, are the ones where you'd like to investigate. Okay? Next, patients with unusual, not unusual I would say, now well recognized, cerebral and splanchnic venous thrombosis. In settings where the long-term anticoagulation is not contemplated, we would like to stop the anticoagulation. And therefore, that stoppage, that is a very important threshold or landmark where you need to take a call. And in these two conditions, whether you would like to stop or not stop anticoagulation, you would like to do the investigation if for any other reason the anticoagulation is not to be continued. So this is again conditional. Individuals with family history of thrombophilia due to protein C, protein S, and antithrombin deficiency in first degree relatives who, and these people who do not have venous thrombosis, yet they are first degree relatives of known patients of protein C, protein S, you may like to investigate them depending on the situation. Individuals with a family history of antithrombin, protein C, protein S deficiency, when considering thromboprophylaxis for minor provocating risk factors and for guidance to avoid, again, oral contraceptives and hormones. So this is the fourth. And fifth would be the pregnant women with a family history of high-risk thrombophilia types. Now, factor V Leiden and the other inherited thrombophilia are not strong thrombophilia factors. Please, factor V Leiden is a very catchy word, and we tend to prescribe that factor V Leiden protein prothrombin gene mutation. They are not important from the point of view of causing risk of venous thrombosis. But antithrombin, protein C, protein S are. And therefore, these are the 3 investigations you would like to ask for in relatives of proven patients of these disorders, where there is a possibility of a risk factor or the person getting exposed to more risk. And of course, patients of cancer, where of course in the morning you had a long talk from Dr. Tulpule. Whom test we have just now heard. When do you test? We did discuss partly, but is there a way of doing these testing in patients who are on anticoagulation? We are talking about a 2-stage testing approach, which I'll see in another slide. But I think we have already mentioned that the course of anticoagulation doesn't change in the initial 3 months, whatever may be the cause, and therefore there is no need to test during that period, and therefore there is no question of testing. Now, this is the kind of test panel one was using maybe a decade back or 5 years back. And you can see the thing consists of almost like 10, 12 tests, and they're all very expensive assays. And now, after one has gained knowledge in terms of the usefulness of these tests, and what I recommend are these 7 tests. Coagulation profile, which is APTT, PT, and thrombin time, and that is very important because of the fact that heparin contamination of blood samples which are sent to labs for testing of coagulation assays is not unusual. That's because of the lines that are placed in these patients and heparin being kept in the lines for patency, and maybe by mistake the nurses may collect from that line, and you have a heparin contamination of the sample, and you do the test, you have all erroneous results. So APTT will tell you that if APTT is prolonged, if it is abnormal, one has to investigate for the cause of prolonged APTT and not for thrombophilia, because thrombophilia doesn't change the APTT. The same with thrombin time as well as prothrombin time. So once you do these three tests, you know the soundness or the reliability of the sample for testing for thrombophilia. If any of these are abnormal, like for example, thrombin time is prolonged, again heparin contamination, or newer anticoagulants, they all cause these things. Lupus anticoagulant. So you have to think of the other possibilities which lead to the prolongation of these screening tests, and therefore their impact, negative impact or the adverse impact on the outcome of the thrombophilia assays has to be kept in mind, because many of the thrombophilia tests are actually APTT based assays. At the end the end point is fibrin formation, and if you have interference with that because of other variables, your test results are going to be wrong. So this is very important for us to remember. Fibrinogen level is something which one should do. Then for APLA, 3 tests that are recommended: protein C functional, protein S free, antithrombin functional, and factor V Leiden, yes, because it is known to happen in Indians, but not prothrombin gene mutation. You can see it is not there. In the previous slide it was there. So these are the tests which you may consider in patients where you'd like to know, after due consideration of the various factors as I just now mentioned, the cause of thrombophilia. The 2-stage approach is basically, it is the tests which are not coagulation based, or they are enzymatic tests or chromogenic tests or genetic tests. They are not based on clotting assays. And there you can do these tests even if the patient is on anticoagulation. But again, you should have compulsive reasons or compulsion to do these tests during anticoagulation. So that is something which you should keep in mind. I have brought the next 2 slides basically to emphasize the role of D-dimer, but I don't want to go through all the points. Simply, I would like to mention that D-dimers are important from the point of view of the decision whether to continue, other than, of course, the reason for thrombophilia that we just now have been discussing. But a patient who has presented to you, you have already treated him for 3 to 6 months. Nowadays, recommendation is 3 months. At that point in time, you'd like to know whether you want to investigate even for thrombophilia, and for which you'd like to stop anticoagulation. Is it safe? You may like to do a D-dimer. If the D-dimer is high, in spite of the anticoagulation treatment of 3 months, that would tell you that there is an underlying ongoing thrombotic process going on. So if that is the case, it is not safe to discontinue anticoagulation. So D-dimer's role is more in terms of decision about continuation or otherwise of anticoagulation under these circumstances than of diagnostic value. It can be of diagnostic value if you want to know whether a person has thrombosis. Yes, there it has, but not in the context of other scenarios. And these are the incidences of various thrombophilic causes in the Western population and the Asian population. And I would like to just briefly bring to your notice a very important observation. And as you can see here, the incidence of antithrombin, protein C, protein S deficiency in Asians, which is highlighted in bold, is higher than what we see in the Western population. Now, this could be, I mean, one would assume that that is a genetic or population difference. But at the same time, one must keep in mind the fact that most of the labs in Asia, in India particularly, do not do these tests on a daily basis. So these samples as they come, in fact, no lab does. As they come, they are not tested immediately. They are frozen down. If the lab is good, they will be frozen down at -20 or below temperature for batching up the tests at a later date. So you're talking about preserving these samples for a variable period of time and then doing the test. So we, many years back, became suspicious of this data, of the Asian data. And we investigated on a serial monitoring of normal plasma samples, which were tested for these three proteins, protein C, protein S, antithrombin, at the time of collection and at a weekly interval for 4 weeks. And lo and behold, what you see is this, that the protein S is the most unstable protein. So when you keep it for a long period, 4 weeks, at the 2-week interval itself, you can see it is going down. And so much so that 5 out of 50 samples that we checked for free protein S, the levels went below the normal range. Normal range was established from these 50 samples, below the normal range, meaning thereby that if I had tested this sample after 2 weeks, I would get a value which is abnormal. I will label this as deficient, isn't it? The same is true for protein C to an extent. Antithrombin is the most stable. And you look back at the data. So antithrombin deficiency of the three was less common compared to the protein C and further compared to protein S. Meaning thereby that part of the data reflects the variability or deterioration of sample on preservation, and therefore falsely reporting higher incidence of protein C and protein S deficiency in the Asian and Indian population in the published data in the international literature. So this is something which we should keep in mind. And therefore we recommend that the labs which are preserving samples for a period of time should derive their normal ranges on the preserved samples for the period for which they are going to preserve these samples. So this is something which is hindsight. I recommend that, and I'm not sure if all labs do that, but that makes a lot of sense to do it, because then you are going to give the results against a comparable apple-to-apple scenario and not against a range which is given by the manufacturer, which might have done 100 samples on a given day and given you all they established their range, versus us, we are doing 2 weeks down the line and we are, giving 5 cases of deficient out of 50. So I think these are fallacies which on the clinical side our clinical colleagues do not know. And nobody talks about these things. But it's very important for us to realize. And therefore, as colleagues, I request you to question these, put these questions to your lab colleagues as to what is your normal reference range? How have you established? Because if my diagnosis is going to depend on management, on what you are going to get from the lab, which is how it is in all cases, you better have a reliable, we are all talking about quality control, accreditation, CAP, NABL, this, that. It's part of that. So I think it's very important. I just wanted to emphasize that, to the clinical colleagues so that you keep it in mind. And maybe these are my last couple of slides. The trend is the word which I had used in the beginning. And you can see here on the right-hand side, the inverted pyramid tells you how from indiscriminate investigation of patients of suspected venous thrombosis with a battery of tests, it has come down to only very selective investigation in situations where the investigation is strictly indicated because it is going to give you some insights that will help you manage your patient and not just get the information for the sake of it, isn't it? And that is how it has happened. So this is borrowed from middle Drop, who is the first author of the ASH recommendation on thrombophilia testing, which just got published in Blood, I think about a year back, from which I had taken that earlier flowchart. So, conclusion, testing for thrombophilia has a limited role in the management of DVT and in deciding about the duration of anticoagulation and should not be performed casually. Thrombophilia testing in asymptomatic relatives may be useful in families with antithrombin, protein C and proteinase deficiency only, or for siblings of patients who are homozygous for factor V Leiden, and is limited to women who intend to become pregnant or would like to use oral contraceptives. So this is a very select group in which you would like to investigate before they get on to taking these pills or plan a family. So this is very clearly an indication where you should do. Observational studies show that patients who have had VTT and have thrombophilia in this case means inherited causes of DVT, are at most at a slightly increased risk of recurrence. So this is something which we should remember. No beneficial effect on the risk of recurrence of VTE was observed in patients who had been tested for inherited thrombophilia. So testing for thrombophilia does not impact, whatever may be the cause, the recurrence of venous thrombosis. This is something which we have to keep in mind. Diagnosing antiphospholipid syndrome, which I didn't cover into greater detail because that's a separate topic altogether, in women with recurrent miscarriage usually leads to treatment with aspirin and low molecular weight heparin, although the evidence to support this treatment also is limited. The right time to investigate a patient with unprovoked DVT is after 3 months anticoagulation and on stoppage of anticoagulation for 1 to 3 months. This is, I think, stretching the things a bit too far. You cannot discontinue anticoagulation for a month or 3 months before you can. I mean, the patient has a risk, he'll come down with another episode of DVT. So practically, I would suggest that these investigations, and why it is recommended, because that gap is given for the synthesis to recover from the liver, because these are all proteins which are synthesized in the liver, and the drugs that are given, they suppress anticoagulation, particularly oral anticoagulants. They suppress synthesis in the liver, and it takes some time for the thing to come back. So if you do the test immediately after stoppage of warfarin, you will get abnormal values. So you must give some time, and that sometime, I would say about 10 days to 2 weeks is maximum that you can afford to give, maybe, keeping in mind the clinical implications. 1 week is also many times okay, because if you get a normal value, you know that it's okay. If you get abnormal, maybe you may like to repeat, because then that may reflect the immaturity, reduced synthesis impacting the value. And D-dimer level post cessation of anticoagulation has an important role in deciding about continuation of anticoagulation after 3 months. And therefore, this point I highlighted earlier. I think that's my last slide. Thank you for your attention.
Thank you, sir. I think that was an exhaustive, absolutely on the point discussion on the topic. I think there are many things which were very ambiguous in our minds, which you have cleared by your slide and your conclusions. Thank you, sir, for this very wonderful talk. We're coming to the end of this scientific session, the last 15 minutes. So quickly, I'll ask Dr. 𝐸𝐬𝐧𝐝 to go through his presentation on anticoagulations, and then we'll conclude with a 5-minute from me on various situations.
Good afternoon, everyone. I'll just talk quickly about anticoagulation options in thrombosis. I'm Dr. 𝐸𝐬𝐧𝐝. I have no disclosures. Everybody knows about the coagulation pathway, the extrinsic, intrinsic pathway, and the common pathway. These are the options that we have, and these are the places that it works. DTI would work at the second last point where a clot is formed. Before that, there is our old heparin, low molecular weight heparin, fondaparinux, warfarin, and somewhere about that is factor Xa inhibitors. Unfractionated heparin, invented 112 years back, is the quickest, most injectable anticoagulant. Works for about 60 to 90 minutes, and then it starts to wane down, renal clearance. We check APTT and ACT during the procedures, and we can easily reverse that with protamine. Low molecular weight heparin is the next thing, which the common ones being enoxaparin and dalteparin. It has longer renal clearance, longer acting, half-life of 3 to 5 hours. Very rarely we need to monitor anti-10A levels, and protamine reverses some effects of that. The next synthetic pentasaccharide, which works specifically on factor Xa, we have been using only for some specific cases like heparin-induced thrombocytopenia. It has least effects on platelet function, that's why. And it can be given once a day, has been used for prophylaxis and therapeutic options equally. The next thing is vitamin K dependent antagonist, which we know as warfarin or acetrom, one of the two commonly used medicines. It has narrow therapeutic window, profoundly altered by medications, our diet, and needs regular INR monitoring. The first one being warfarin. It is slow acting, takes 2 to 3 days to work, has half-life of over 40 hours, has hepatic elimination, and whenever we need to reverse, probably for surgery or for trauma, we give vitamin K and FFPs. Acetrom is the synthetic one, which works a little faster, is more predictable, has less drug interactions. And probably this is why we are all here for, basically the newer anticoagulants more than anything else. There are many more which had come and which have gone out of production because they didn't work well or they had problems with bleeding. But they're basically divided into two types, which is factor 2A inhibitors and factor 10A inhibitors. The 2A inhibitors, the injectable is ergatroban, and oral one is dabigatran, whereas the injectables being fondaparinux, as we discussed, and the oral medications of factor 10 we'll speak as we go. Ergatroban, given as an intravenous infusion, half-life of 39 to 51 minutes, excreted more in feces, so less renal clearance required. Mainly used in HIT and his patients with history of HIT or undergoing percutaneous coronary intervention. But now I guess we are using more of fondaparinux, so ergatroban is also going out of production as such. The other one, oral, direct oral inhibitors being dabigatran. All the DOACs roughly work within 2 to 4 hours, work for about half-life being around 12 to 15 hours. Mainly excreted renally except apixaban, which is excreted more through liver or feces. And they are generally contraindicated with renal clearance of less than 30. Praxbind is the antidote for dabigatran in this case. It comes for about 1.5 lakh rupees, so it's a bit pricey on that side. Few trials probably discussed before as well, but I'll just rename them Rely and Recover. All these trials for DOACs or NOACs as they're called were for non-inferiority trials and safety, and they are non-inferior and safer than warfarin. Rivaroxaban, another medication that we've been commonly using, comes from dose of 2.5 to 15 milligrams to 20 milligrams now. They've been used in prevention and treatment of venous thromboembolism in orthopedic patients, common patients, stroke patients, and now we have 𝐸𝐻𝐼𝐳 alpha, which is its antidote. Few trials, it's all Einstein DVT trials, record trials, which showed that they were safe as compared to enoxaparin and as good as warfarin. Apixaban, which is one of only important thing about apixaban over here is that its excretion is biliary, and it is again used for the same kind of indications. Trials related to that, just to name a few: Advance, Averroes, and Aristotle. Then we had edoxaban, which came from Japan in 2011, and there is Hokusai-VT trial, which showed its safety and clinical features. I'll just come to comparison of warfarin and DOACs. To name a couple of things here in the whole chart is that warfarin takes time to work and takes time to come down, whereas all the other ones work quickly and the effect goes off maximum in 48 hours completely. Rivaroxaban is something that you have different doses available for these, and apixaban is the one where if you have a renal patient, you can use it in a better way, or probably you would be less worried about their safety in terms of bleeding risks. Many guidelines have been here. We have chest guidelines, critical care guidelines, American cardiology guidelines, which says why these medications are now safe, and we have been replacing almost all our medications, whether it is warfarin or acetrom or enoxaparin, with oral medications which have predictable response. Few more things. This is not, these things have been started. The newer medications have been started because of previous many more studies on warfarin. There's COMPASS trial and Voyager trials, which have come recently, probably in the last few years, less than 5 to 7 years, which have shown that you can then use these in arterial cases as well, which help in improving the long-term outcomes. Thank you.
I think that was an excellent summary of all the drugs. And since I started this all, I'll just take 5 minutes to just quickly take you through. Yeah, so I'll quickly take you through. I'll quickly take you through 5 or 6 special situations, just a practical update for those of you who will go back and probably come across these situations in your OPD. It's not exhaustive, but very quickly. Scenario 1, 34-year-old lady, second trimester of pregnancy, travels to her mother's house by road 6 hours, wakes up in the morning, swollen leg left side, not otherwise having any symptoms, goes to a GP, color Doppler, acute DVT extending up to the common femoral vein. What is the management? Typical situation. So this addresses a special situation, which is DVT in pregnancy. So in DVT in pregnancy, the only drug approved for use is enoxaparin, and you need to continue it till labor. Just before labor, around labor, you switch to heparin. Why you switch to heparin is that in case there is a PPH or a bleeding, you can reverse it immediately, right? So pregnancy patients start with enoxaparin, no other drug is approved, and switch to heparin during the labor period. Scenario 2, 25-year-old lady, lactating mother, comes to OPD, acute DVT, very common situation. Lactating mother, acute DVT, what is the management? In DVT, appropriate for medical management, warfarin is the drug of choice. All said and done, every possible drug that has been discussed by Dr. Piyush has a place under the sun, under some situation or other. So nothing has been actually discarded saying this has come, so that is out. Pregnancy, enoxaparin, similarly DVT, lactation, warfarin is the drug of choice, but it's a very severe DVT and you require an intervention, then you need to suppress lactation by drugs or whatever way, and then go ahead with your intervention. Scenario 3, acute DVT, patient with a creatinine of 3.2. If your lab range says normally 1.2 up to 1.2 is normal, you have this patient comes with an acute DVT, creatinine 3.2. What is the management in a renal compromised patient, right? Now you saw Dr. Piyush's presentation, and he said apixaban is fecal excretion. Majority of it is excreted through bile. So if the patient of CKD with DVT is not fit for an oral medication, injection deltaparin preferred to enoxaparin. Why? Because it's a smaller molecule, more easily excreted. But if the patient is on dialysis, then probably the best drug would be regular heparin, as Dr. Piyush has shown. If the patient is not on dialysis and can take orals, then for whatever I just described, tablet apixaban is recommended in a reduced dose. And you can take, if the eGFR is less than 15, then in a dose of 2.5. So this is the only NOAC which actually has a recommendation for use even in low eGFRs for the reasons I mentioned. If the patient is on dialysis, I would still prefer warfarin, though there is some evidence, some nephrologists still, they've switched to apixaban in dialysis patients. But by and large, I would prefer to put my patient on warfarin if the patient is on dialysis. Scenario 4, you have this 78-year, very common scenario we see in our hospital. 78-year-old female, admitted in ICU, last 7 days, cerebral bleed. Intensivist notice a right leg swelling, last 24 hours. Got a Doppler done, acute DVT involving the common femoral vein up to the iliac vein. What is the management? We mentioned, one of the speakers mentioned, absolute contraindication to giving any anticoagulation. So this is an absolute contraindication to giving anticoagulation or any thrombolytic. These are the patients where you need to put in a filter. Scenario 5, 75-year-old male admitted to in the ICU for urosepsis, very common condition again, develops an acute DVT of the left leg, get a Doppler done, DVT involving the common femoral vein, started on injection deltaparin, fragment, as most would know it. How the platelets are now around 80,000 and they're showing a downward trend, and you get a call from the intensivist saying that you put him on fragment or LMWH, but the platelets are going downwards. How would you manage this? You screen for a HIT, that is heparin-induced thrombocytopenia. We've not discussed it because we've not discussed exhaustively all the possible complications. But heparin-induced, so there are certain conditions where the heparin can actually reduce the platelet count. And in these conditions, injection fondaparinux is the drug of choice. So in a low platelet with acute DVT where you're given heparin, you suspect HIT, fondaparinux is the drug of choice. Scenario 6, 45-year-old female, acute thrombotic, real-life scenario. It's a nightmare, right? Which is why I'm sharing it. 45-year-old lady with acute thrombotic limb ischemia, taken up for surgery, recurrent clotting post-operative, hiked up the heparin, greater than 35,000 units per day, APSTT still not in target, still clotting in the post-operative period. So thrombosis, arterial thrombosis, not responding to the conventional LMWHs. You need to investigate for acute phase reactants and all these other things, splenomegaly and all that, but this is where you need a drug, injection Angiomax or bivalirudin, and this is the dose. We face this. Unfortunately, this is not easy to go by. You don't get this drug easily, and we, not so long ago during the COVID period, we were faced with such a case where patient came with a limb ischemia. We thought all these things that you discussed the whole day, opening the artery, removing the clot, it might seem so easy, giving heparin, goes back to the ward, clots again, brought back again opened the artery, giving heparin, still clotting on the table, going back, finally landing with an amputation. It's a nightmare. So you have certain cases where despite all your drugs, your conventional drugs that have been used, you still get thrombosis. And so thrombosis is a nightmare for society, and which is why we probably thought it's appropriate to have a meeting like this, because very little is known, very little is discussed about thrombosis. And here is a drug, very rarely used, but good to know that this sometimes can be a lifesaver and a limb saver for patients. So with that, thank you very much, and thank you for all of you for staying with us. And I think with this we come to the conclusion of our, there's just a small ceremony as this is hosted by the Vascular Society of Maharashtra. We had at the beginning of the day, beginning of our planning, we had actually said that since March being the DVT month, DVT awareness month, so we had put up a poster like this saying that there is an award for a best e-poster on venous thromboembolism awareness, and we had said it for it's basically meant for postgraduate trainee students. And we got quite a few entries. People posted in their e-posters, and we said that we should be fair, so we sent it all to a neutral judge outside the state, and we anonymized all the names so that we could get a fair kind of a, result. And we had a champion and a runners-up, and we got this. I think one of them is present. One of the two is present in this hall. I'll put up the poster that won the Best Poster Award. This is the Best Poster Award for PT awareness. And I'd like Dr. Amish Mathi, Secretary of our 𝐬𝐮𝐫, you please do the honors. Please announce whose poster this is. And you can call the person on the dais.
First e-poster award goes to 𝐯𝐚𝐬𝐿.
Get your certificate meanwhile. And the runners-up goes to Dr. Balakrishna, TS, from SRMC Chennai. I think he's obviously not here. I hope he's watching this on the live streaming, but we'll send him the award. So with that, we come to the conclusion. Thank you, everyone. Have a good Sunday or whatever remains, and thank you for coming. Good night.